Sir, we are going live now?
Yes, sure.
Yes. Yes.
Nisha, are we live?
We are
Yes,
live, ma'am.
Rashmi, you can start.
Yes. So a very good afternoon, everybody. It's wonderful to see you all on this bright, sunny Saturday afternoon. I extend my heartfelt welcome. Nisha, I would like to put your first slide, Nisha.
Yes, ma'am.
I extend my heartfelt welcome to chief guests of honor, faculties, chairpersons, respected delegates, and friends. In association with Corona Pharma Remedies, ISOPARB Vidarbha chapter, Amravati Obstetrics and Gynec Society, and Deoli Obstetrics and Gynec Society, we are really delighted to present before you today's webinar workshop on making LSCS safe. What an auspicious start. Today we are celebrating Shiva Jayanti. Let us seek blessings of Goddess Saraswati, and I request all the dignitaries to kindly join for the online inauguration and platform. Thank you. The organizing chairperson of today's webinar workshop is Dr. Surekha Taide. She is Professor OBGY JNMC Vartha. She is a teacher, mentor, guide to many students. With high grade of clinical research attitude, she is dedicated to the betterment of her students. Not only that, she is majorly involved in her many community projects. With more than 100 research paper publications and more than 20 chapters in books, oh, the list is so impressive. Madam, I must say you are an influencer and a trailblazer. May I call upon Dr. Surekha Taide for her welcome presidential address.
Respected seniors, teachers, colleagues, viewers, and teammates. The capacity to learn is a gift. The ability to learn is a skill. The willingness to learn is a choice. And the inclination to teach is a passion. And of course, Indian Society of Perinatology and Reproductive Biology, as well as the two societies which have joined together, Deoli Sawangi OBGY Society and Amravati OBGY Society, are here to fulfill their commitment to contribute towards learning. My predecessors as President, Dr. Lakshmi Srikhande ma'am and Dr. Sneha, has created a roadmap to follow in their footsteps, to teach, and of course, interconnectedness through the use of digital media also. Our vision to contribute in the region as well as nationally is five-pronged: academic and professional training on rollout of all these trainings on practical topics, content creation, resource building, and of course, practicals, because we want to assist the practice through protocols, community engagement to create health awareness, and also to reduce the primary prevention of various disorders. Service through training of healthcare providers in outreach areas through public and private partnerships. Contribution to the multi-centric research. All in all, we are wanting to reduce the maternal and neonatal mortality and improve health of mothers and also the babies which are born. I welcome you all to participate in this focused webinar, Making Caesarean Section Safe. To all the faculties who have joined, our chief guest, Dr. C.N. Purandare sir, our guest of honor, Dr. Uday Thanawala, all the faculties who are distinguished faculties, the chairpersons, and the panelists and the participants who have joined here. I welcome you to this very focused webinar, which is not only interesting, but also which will affect our practices. Thank you very much. Rashmi?
Chief guest today is none other than respected Dr. C.N. Purandare sir. I call upon Professor Dr. Surekha Tade to kindly introduce us with Dr. C.N. Purandare.
Dear all, it is an honor and proud privilege to introduce to this august audience our chief guest of today, my mentor, inspiration to all, most successful Foxian, collaborator, great researcher, teacher with passion for medical education, person who has reached pinnacle of academic as well as social excellence, who has saved lives with community health programs conducted not only in India but all over the world. Teacher of teacher, great stalwart leader, Dr. C.N. Purandare sir. Please put your hand together to welcome sir, who has been a teaching experience of more than 40 years, not only in India, but worldwide, and especially, I think, in Ireland, who shaped the growth trajectory of MOGS, Foxy, and he has moved to be the president of FIGO, making us feel so proud of you, sir. Foxy was given an academic focus with his leadership. He provided various national development programs, created self-sustainable systems, formed up the financial policies of Foxy, and sourced funding, cemented national and international partnerships with Government of India, UNICEF, WHO, MacArthur, IPAS, PSI, then SAFOG, AOFOG, many more. Sir, you're an inspiration for all of us. Foxy moved from an organization which was in financial loss, but then under your leadership, more than 50 million of turnover and 20 million of profit per year. That is what you have given as not only a teacher trainer, but entrepreneur also. Reduction in maternal mortality, population stabilization, prevention and early detection of genital cancer, and not the least, saving lives. That was your passion, is your passion, and is your arena of work. We welcome you, sir, to guide us.
Thank you very much, Surekha. And when you requested me to be here for the ISOPARB meeting to chair it, I was supposed to be out of town today, but fortunately it got shifted to tomorrow. So I was able to join in here. And it has been a long time since we met really in person because of this COVID situation. It has always been on Zooms, and I can see Dr. Zungare and so many of them in the audience there, which we have had very good association during my tenure in Foxy. I've been to the Amravati OBGY Society and Sawangi Mege also, and I think if those who are there in Sawangi Mege will recollect that I was instrumental in starting that society there, when there was so much of opposition saying that Sawangi Mege does not have a municipal corporation. It does not have this, it does not have that. And there was so much of opposition which had to be literally overruled, and to say that if some society has to be formed, don't go whether there is a municipality or there is a railway station, and that's not the point. How many people are there who are eager to work in that society and work on it? So, and I have had the privilege of giving orations there. I have had the privilege of operating in Sawangi Mege Society also, and Amravati. and it's been a great association. And of course, your predecessor Lakshmi also had an ISOPARB meeting, which I remember attending, and she is a true Lakshmi. She keeps on. She will make sure that the next president who's coming in or chairman who's coming in will have enough funds to take the organization forward. So it's been a great association. Talking about today's subject, I think it is a very important subject, and it's essential that all the obstetricians, there has to be a technique which has to be accepted as a standard technique for cesarean section. Anybody does anything and says that I've done a cesarean, whether it is single leg closure, double leg closure, and trying to deliver the babies through extraperitoneal, through peritoneal, and all sorts of things. But there has to be a system in which things should be done, and there should be an ideal method of cesarean, which I try to get it sorted out at FIGO level, though it was partially done and not completed. But at least during that tenure, I was able to bring about the classification of the 10-point from Robson, which was accepted finally at the WHO level, where I appointed Robson specifically to represent FIGO on WHO to promote the 10-point analysis of labor and so on. So the cesarean sections are very important, and the incidence of it is rising world over. I'm not saying that it's only India or anywhere. You look at any of the statistics from Egypt, in a matter of 10 years, it has gone up from 8% to 54%. So it's all over the world. There's no point in blaming, saying that Indian obstetricians are doing cesarean section more than where it is needed. It should be done. There is no question about it. And the need, it's a need-based thing. And WHO initially said that 15% should be the cutoff point, which they themselves slowly got out of it to say that when needed, one should do it. And it's not the percentages which are important, which need to be looked into as far as the cesarean sections are concerned. But with all said and done, it's also true that sometimes unnecessary cesarean sections are being done. Cesarean section is something which is a 20-minute job, while a normal delivery, you spend much more time working on that normal delivery. And actually speaking, I always propagated that you should be paid more for doing a normal delivery than a cesarean section. And if not, make a standardized price that you will charge X amount for delivery, whether it is cesarean, whether it is normal delivery, or whatever it is, so that nobody should say that the obstetricians are doing cesarean section because they are going to get more money. It's not the money. It's the net benefit to the patient and the baby that one has to look at, and that is what we are always looking at. And it's not barring maybe a few black sheep, which are there in all professions. The decision to do a cesarean section has always been for the mother and the baby's welfare. And but if the way the trend is going, if you were to do the cesarean sections without indications, just going on doing them, then there will be only two types of deliveries. I always say there will be one by cesarean section and the other vaginal delivery, because there is nobody present there around and this patient delivers vaginally. The moment a doctor walks in, it is a cesarean section. And I think that trend has to change, and that thing has to be controlled as far as the cesarean sections are concerned. So I'm sure you will have a lovely CME today with so many good speakers and so many people there discussing the issue. And I hope that maybe ISOPARB and Foxy, and now that Lakshmi is going to get in the shoes of the college, get a standardized cesarean section operating protocol done, in the sense that the surgery technique also, whether what suture material you will use, how would you use it, what are the things that are needed, and it should be a standardized thing which should be followed by everybody, so that there is no, when you're comparing, you know that what the situation is. You can't say that, well, section done in Sawangi Mege and patient has come to me, they must have messed up everything and I'm going to do it properly. It's not that. It is a standard protocol and surgical technique that's followed all over, which is uniform. So there is no question of any ambiguity in what is happening and how things are. So all the very best to you. And I'm sure you will all enjoy today's CME. Thank you very much.
Thank you very much, sir. And I reiterate that uniform protocols, like sir has said, skills of cesarean section will definitely improve the quality of care which we are giving to our mothers. Thank you, sir, for those words of wisdom. And now I would like to welcome, before that, I would request the host to open up the video option of all the faculty. Some of my faculty are not able to open the video. So host, a request. And with that, we move on to invite our guest of honor for today, Dr. Uday Thanawala, sir. Dear friends, ICOG, the academic force of Foxy, is now a force to reckon with. Just few weeks prior, we have witnessed the grand virtual convocation of ICOG, with FICOG awarded to Foxians who are having an academic flair under the leadership of, again, a very passionate teacher, Dr. Uday Thanawala, a person with a great vision. We are now witnessing an escalation in the ICOG's reach with PG forums, specialized courses, journal clubs, CMEs and conferences, fellowships, and of course, digital resource creation that ICOG is contributing to such an extent. Presenting to you the chairperson of ICOG, who has risen as a leader from the township of Vashi to make his presence felt at the national forum as a national leader. Come from Navi Mumbai, presently is the chairman of College of Obstetrics and Gynecology of India. He has served as vice president. He has served as treasurer, chairperson of the Medical Disorders Committee of Foxy, and of course, on various other posts. So now we have with us our guest of honor, Dr. Uday Thanawala. Is he here? Uday sir was going for a surgery. So
the surgery, yeah.
Yeah, so we welcome you, and we'll be seeking his blessings when he comes back from the surgery. And with that, we move forward, Rashmi.
Yes, ma'am. Our next guest of honor is Dr. Lakshmi Shikhande madam. She is our own Vidarbha Kanya. I would like to request Dr. Shikhande madam to kindly guide us on this occasion.
Thank you so much, Rashmi. What can I say? Dr. CN sir has already given us the direction, and he has already blessed us for the success of this webinar. And as sir, you have said, I have really rightly chosen Surekha to follow me in my footsteps as far as Vidarbha ISOPARB is concerned, because I know she will take it to greater heights. And today's topic is very, very practical, and that is why, Surekha, every obstetrician wants to log in and wants to update their knowledge. And sir, as you have already said, in ICOG, we will definitely, under your guidance, we will try to have the national thing which you said, it should be a national protocol and everyone should have the uniform procedures for performing cesarean section. We will definitely do it, sir. It's a wonderful idea. Surekha and team, I wish you all the very best for the success of this webinar.
Thank you, ma'am.
Thank you, ma'am. So let us move further to our scientific session. Session 1 is difficult LSS, floating head or deeply impacted head. Why worry? Learn from experts. The speaker is none other than Dr. Sheila Mane, and the respected chairpersons are Dr. Jayam Kanan Madam, Dr. Aruna Suman, and Dr. Trishala Dhendre. Dr. Jayam Kanan Madam, actually she needs no introduction. Nisha, will you put the slide, please? Dr. Jayam Kanan Madam, she is the first Indian to receive RCOG award for her distinguished community services. She has been Fox's Adolescent Health Committee chairperson 2013 to 15 and has won Best Committee Award. She is Emeritus Professor Tamil Nadu, MGR Medical University, and Managing Trustee of GHR Garbha Saurakshik Group of Institution. She is the Director of GFC Fertility Center, Trichy and Chennai, and has been Vice President Foxy 2018. We welcome you, Madam.
Thank you.
Our next chairperson is Dr. Aruna Suman. She is the Professor OBGY, Japtia Government Medical College, and congratulations, Madam. And she is VP OGSH, and she is Joint Secretary Foxy 2021 and 22. Welcome, Madam.
Thank you, Dr. Rashmi. Thank you, Dr. Professor Sureka. Thank you so much. It's my privilege to be here.
And next chairperson of the session is Dr. Trishala Dhendre. She is the treasurer of ISOPARB Vidarbha chapter, and she is director at Sri Purva Nursing Home. She is a recipient of NOX 2019-20 gold medal, and she is a regular AICOG faculty. We welcome all the chairpersons, and for this session, I hand over to the respected chairpersons.
Thank you, Rashmi ma'am. Thank you for the kind introduction. Am I audible?
Yes.
And should I start? Yeah. A very good evening to one and all. I extend my gratitude to the organizers with the ISOPARB, Deoli, Sawangi, and Amravati Obstetric Gynec Society for giving me an opportunity. With this, I really feel privileged, and it's an honor and proud privilege to introduce none other than a great mentor, teacher of teachers, motherly figure, larger than a life, which can be made out looking at her biodata and accomplishments. A nationally and internationally acclaimed faculty, none other than Dr. Sheila Mane ma'am. Ma'am, you are the ICOG Governing Council member. You are President of ISOPARB Society, Menopause Society, Bengaluru. Your contribution to Foxy just cannot be measured in the terms of positions you held. Hats off to your untiring efforts working for Foxy more than 20 years. You are currently the DNB faculty. You are the Vice President of Foxy in 2014. You are the Teachers Par Excellence and received the Best Teachers Award from Dr. B.R. Ambedkar Medical College. You as well, for Safe Motherhood Committee, you have received the Best Society Nehru Datta Hansutia Award. As well, you are the receiver of the MS Signature Award too. You have served for WHO in the capacity of National Facilitator Adolescent Health. Ma'am, the list is very long, it is endless. So presenting before you a courageous, challenging, a passionate teacher and a dynamic stalwart, worldwide known as the PPH lady, who always believes that nothing is impossible. So welcoming Dr. Mane ma'am, you are most welcome for the very, very important session of tackling the impacted and the floating head in cesarean, difficult cesareans. So lots to learn from you.
Thank you. Yeah, thank you so much for those kind words. And I feel like coming home because it is Vidarbha ISOPARB.
Yes.
Okay, and my Marmavate. So
Thank you, ma'am.
And
Madam,
we are,
unmute yourself.
Sorry. Thank you very much for those kind words. And Trishala, and I feel like coming home because I belong to Vidarbha and Amravati, Nagpur, all of you are so near and dear, and as well as I'm privileged here now to give a talk. And thank you, sir. I think you're here and I'm really privileged, I think, when you are here as a chief guest, and a lot to learn from you, and we still keep learning. And thank you, and please bless us, bless all of us. Can I start sharing this? Sharing my screen? Yeah.
Yes, ma'am. You're able to share, ma'am?
Yeah, that's what now. I don't know what is happening.
You go to the share screen option.
Yeah, I did that.
You see your desktop? Yes, ma'am. We're seeing it now.
I think I have to go back.
Yeah. No, you can go back to the first slide. No worries.
Yeah. Is it there now?
Yes, ma'am. No problem.
Thank you. Thank you, Dr. Surekha Taide, Dr. Rashmi, Dr. Lakshmi Shrikhande, Dr. Sneha Buyar, and good afternoon to everyone. Dr. Pushpa Jungare, Dr. Mitra Saxena, Dr. Uday Thanawala, and everyone. And sir, namaskar. So the today's topic, that is difficulties during baby delivery at cesarean section, demanding fine-tuned obstetric skills. So most commonly surgery performed in OBGYN, and it's often perceived as a safe alternative to difficult vaginal delivery. But there is an alarming increase in the rate of LSCS, almost reaching 50%. And there are some reasons for increasing that. That is increasing comorbidities, previous cesarean sections, as we have not given importance to reduce the primary cesarean section. Maternal request still remains with us, and fear of litigations. Now, LSCS became safe because of better anesthetic techniques, reduced infections, availability of blood and blood products, and improved surgical technique. But is it foolproof? Can it give us nightmares? And as we are doing more and more cesarean, sometimes we face challenging situations. All of us, we know life is full of difficulties. We have to meet them, greet them, and defeat them. Now, difficult cesarean section, if we look at a literature review by Federica Visconti, there are 4 categories of difficulties: difficult access to lower uterine segment, complicated fetal extraction, lacerations, organ damage, and abnormal placentation. So these are the 4 categories. Now, most commonly performed cesarean, as we say, and there are technical nuances. That is, we have to have adequate knowledge of fetal lie, presentation, station, degree of flexion, and position of occiput. Maintaining flexion of the fetal head during delivery, delivery of shoulder and body with gentle traction, availability of a skilled neonatologist is important, and decision to deliver by emergency cesarean section for a fetal compromise and actual surgery should preferably not exceed 30 minutes. That means that is the category 1 cesarean section. Now, when we look at the cesarean section deliveries and what causes difficulty, just to enumerate: abdominal and uterine access, the incisions can be financial, modified Joel Cohen, lower segment placenta, or fibroids. Craniopelvic relationships, that is floating head and deeply engaged head, abnormal positions and presentations like transverse lie or breech and deflexed head, even prematurity, multiple pregnancy, fetal malformations, and conjoined twins. Now, there are challenges due to access. I will not go into the details. I think there is a panel, so all those things will be discussed. Okay. Then even the placenta, I think all those things I will focus on my topic, that is delivery of a floating head. Preoperative checkup and assessment is very important. We have to confirm the placental location, anticipate poorly formed and vascular lower segment. We may have to modify the incision. Fetus should be manipulated into a longitudinal lie and steadied by lateral support, because sometimes it is a floating head, it can become oblique also. Membranes ruptured and liquor drained and allow the head to descend and then deliver after flexion. The other options are manipulate into occipital anterior or posterior position followed by instrumental delivery, that is either by forceps or by vacuum. Now, instrumental delivery at cesarean section for a floating head. Okay, and I'm so happy that sir shared with us that he's used to deliver the baby by release forceps. And sir, I must tell you that even I do that, and I don't like too much of fundal pressure and all that. And I think if we use the outlet forceps, it really helps us. So first you rupture the membrane, allow the liquor to drain, that helps for the head to descend. And in that case, the head also remains in a flex position. And if it is not, then we should make it, see to it that the blades are applied over the parietal bones. So it is in a transverse position, and then it becomes easy, okay, for us because, and the minimal traction is required. So it enables flexions, controls delivery, and also reduces trauma. So these are the advantages of applying outlet forceps for the floating head in cesarean section. Now there are many forceps, now we have available release forceps, that's all we are using, but these are the Professor Piley's forceps, and they are different. I mean, if you can see, you will find a smaller size, a short one, and the other one also. And particularly this was made for the premature baby. And sometimes for the premature baby, we really face a problem because the head is so small, we may not get the grip. So you need a smaller forceps, and I have this and I use it for the smaller babies. So a mini forceps and can be more useful for a premature baby or a smaller head. And there the chances of slipping are not there, as well as it can fix well over the head of the baby. Now the other guys also, we can also use the vacuum. Now it can be used if there is a floating head. Types of various vacuum cups are available for use at cesarean. I think those rigid cups are not there now. The bird's cup, soft cup, elastic cup, plastic cups, even the kiwi, which we use even during vaginal delivery when it is occipito-posterior position, because it helps to correct the rotation. Okay. Now, while we have to see that we are using a suitable size cup is used, and if a soft cup is employed, it is partially collapsed by the hand of the operator and then introduced through the incision. Now, these are the, there are advances in vacuum design and there are varied options available. Definitely the first one is no more used, but we have the Silastic, we have the Kiwi. Now, particularly which is available for cesarean is also again with the shaft need not be so long, where it can be easily connected with the suction apparatus. Now, rigid cups are turned sideways and the edges of the uterine incisions are gently spread. The device is slipped in. The cup is applied directly to fetal scalp as near the posterior fontanelle as possible and over the sagittal suture. The knob on the cup should be in the direction of the occiput. The careful check of cup placement follows, that is mid-sagittal over the pivot point, and the finger is swept around the cup to ensure that no maternal tissue is interposed between the cup and the head. Then during traction, the pressure is applied with 2 fingers only, thumb against the dome of the cup and the index finger on the scalp in front of the cup, for the firm contact with the head that prevents the cup detachment. Traction is in a direction always perpendicular to the plane of cup, that is calvarium. And oblique traction, for example, an angle of even 10 to 13 degrees reduces the effective traction force almost by 25 to 50%. Traction is discontinued if an audible hiss is heard, signaling loss of vacuum, that is if the cup is not properly applied. So for the floating head, we have the outlet forceps or we have this. But we have also seen people, those who are not used to this, they allow the liquor to drain, then the head descends down, and then they try to extend it using their right hand as a lever and try to deliver the head. Now, difficult delivery in second stage of cesarean section. Second stage cesarean section accounts for 1/4 of all primary cesarean sections. Done at full cervical dilatation with impacted fetal heads are technically difficult. Quite often, there is a reduced lacquer because it's a prolonged labor. Lower segment is thinned out and edematous. So associated with an increased incidence of maternal and fetal morbidities. Procedural consents are essential. That means whatever we do, even for a normal vaginal delivery, even with the Lakshya also, we have to inform the patient and inform them whatever we are doing. Skilled anesthesia and neonatal supports are required. Now, again, the preoperative check and preparation. Being a second stage procedure, patient is often exhausted. So ensure good well hydration. Yes, stop the oxytocin drip. Awareness of signs of impending rupture should be kept in mind because it's a prolonged labor. Trendelenburg position may help in disengaging the head, but it's not always possible. Catheterizing the bladder is important, but can be difficult as the head is deeply impacted. And bladder is edematous, so urine can get blood stained. Keep the catheter in situ for longer post-delivery. During baby delivery, vertical extension in the lower segment to the bladder. So check the bladder post-delivery because as the head is deeply engaged while delivering, that can happen. Anesthesia, regional anesthesia is preferred, but challenges of positioning are always there. That is left lateral position or sitting position because patient is getting contraction, she is exhausted and tired. We have to stop the oxytocin drip. If epidural can do a top-up, that is the advantage of epidural. And sometimes general anesthesia may be required due to odd positioning. Now, the tips for a safe delivery of a baby, pre-plan the uterine incision. Always give a curvilinear incision on lower uterine segment with concave side up. If one goes very low in the lower segment, there is a risk of cutting through the cervix and suturing may be difficult later. Okay, remember cervix at this time is fully effaced and lower incision on lower uterine segment should be, very low incision should be avoided. Okay, now the methods of delivery opted for Trendelenburg position to facilitate disimpaction. After opening the lower segment, attempt can be made to overcome the negative pressure by insinuating fingers below the presenting part and delivery of the baby, but may be difficult. Now, why there is a vacuum? Because the liquor is drained out and the head will get sucked into the vaginal canal. Sometimes if you're not able to pass your fingers, even we can pass simply a simple rubber catheter between the uterine wall and the head because that helps to reduce the vacuum. Now, the methods of delivery are pushing the impacted head manually or with fetal disimpactor. Okay, so now there is a Tideman tube, that is fetal pillow is also available. We don't have it still, or a LS disimpactor. Now the techniques are reverse breech technique, Patwardhan manure, which all of us we know now and we have really learned from our own people. Now this is the fetal pillow, okay, which can be used, which can be inserted and then it can be inflated with the help of the syringe, so that will help to push the head up. Or we know most of the time we also follow the push technique. Now we know the disadvantages of push technique because we don't know in which direction we are giving the doing the disimpaction, and the chances of extension of the incision over the uterine segment are very high in push technique. Now coming to the reverse breech extraction, that is by pulling the legs of the baby and delivery by breech. Pull method, that is the reverse breech technique. The main operating hand of the obstetric surgeon is inserted upward inside the uterine cavity, and this is mainly helpful when the back is posterior inside the uterine cavity to find and grasp a baby's foot and deliver it along with ipsilateral leg through the uterine incision. This brings the other leg into the operative field. The surgeon then grasps both the feet and proceeds in a manner similar to that practiced in vaginal breech extraction. Okay, so this is reverse breech extraction. Okay, first the extraction of the breech and then you deliver the shoulder, and lastly we have to deliver the head as we deliver it in a like you allow it to come out and then deliver the head at the end of the extraction procedure. Now coming to another method, that is when it is anterior. This maneuver is unique technique introduced in 1957 by Dr. Patwardhan to ease the delivery of the deeply impacted head in second stage, and which was published in way back in 1957. Okay, that is by Dr. Patwardhan and Dr. Motasha. This maneuver needs expertise but is safe and has minimal complications if anticipated and done skillfully. Skill labs can be used to train the resident doctors and needs to be more widely publicized and utilized. Now, if the back is anterior shoulder is delivered first, baby rotated, posterior shoulder is delivered, then the fetal trunk and the breech delivered, followed by the fetal head. Modified Patwardhan's method, if the baby's back is posterior, anterior shoulder and corresponding lower limb is delivered, then the contralateral lower limb, the fetal trunk and the breech is delivered, then the fetal contralateral shoulder, and finally the fetal head is delivered. So here the hand is out, so the contralateral, the fetal leg is delivered. Then you can hold both the legs, deliver this, and then automatically this side shoulder will come out. Okay. Anterior, in case of occipito anterior and transverse position with the head deeply impacted in the pelvis, incision is made a little higher in the lower uterine segments. The shoulders present at the incision level. The anterior shoulder is delivered out by hooking the arm first. With gentle traction on this shoulder, the posterior shoulder is also delivered. And then surgeon holds the trunk of the baby gently with both thumbs parallel to spine, and with gentle fundal pressure given by assistant, the buttocks are delivered, followed by legs. And I know that the people, those who are working in medical colleges and in institutions and district hospitals, still we get the referred cases, and the patient do come in late second stage, where we get the situation where we have to use this technique. And I must tell you that the people in institutions are really, I mean, they are more experienced. And as sir said, that the people should be exposed to these techniques, because it's very important to deliver the baby safely. And once somebody starts practicing, it becomes really easy. So the body, the breech, and lastly the head. So again, the back is posterior. I think again a challenge, follow clockwise pattern, which I already discussed, I think, about this. Now, post-operative period, bladder is edematous, so urine may be bloodstained. Keep the catheter in situ for longer post-delivery. Patient may have had an episiotomy in an attempt for vaginal delivery, so episiotomy care is needed. Adequate analgesia, mobilize as soon as possible. Okay, Flotron, low molecular weight heparin after 6 hours post-regional anesthesia. Reassurance and support. Extension of incision also has long-term implications on the patient's future obstetric career, and it is a contraindication to allowing subsequent vaginal delivery. So a complete analysis of sequence of events is essential to counsel for the future. Okay, then these are the certain studies where a retrospective analysis of 135 cesarean sections done in second stage at tertiary care center in New Delhi. 71 babies were delivered by push and pull method, and 64 babies got delivered by Patwardhan technique. Extensions, traumatic PPH, and need for blood transfusions were also less in Patwardhan technique when compared to push and pull technique. Baby outcome was almost similar in both the groups. These are again the fetal head elevators, which we have really not used, but if there are postgraduates, they should know that. And this is the fetal pillow, which I already mentioned about that. That is, the fetal head can be elevated by at least by 2 to 3 centimeters, and there are less incidences of lacerations. So dear friends, what does evidence say? One more thing I would like to add in the fetal floating head is, I was trying to show that video, but it didn't happen. We can also use the vectis. Okay, and we have one vectis available here, which is angled. So we can use only one blade also to deliver when it is a floating head. So what does evidence say? Conventional method versus reverse breech extraction. Extension of the uterine incision occurred in significantly more women during cephalic delivery as compared to reverse breech extraction. So all of us, we know that the extension can be really traumatic because it can get extracted to broad ligament, can cause traumatic PPH, and we may really have to, we see that the morbidity will be more. Outcomes of second stage cesarean section following the use of a fetal head elevator device, again a systematic review and meta-analysis. Pregnant women having full dilatation, FHED at full dilatation, CS had a lower risk of uterine incision extension, need for blood transfusion, and operative complications. That is with the use of fetal head elevation device. Thank you very much for patient hearing. I know that this August gathering, all of us are really here experienced, but thank you for giving me the opportunity to sharing my thoughts and my presentation for such an important topic. Thank you.
Thank you, ma'am.
Sheila. You have been really great. I know you can do wonders.
Thank you.
I'm very happy about it, and I know very well that you can do the best. The present floating head cesarean is one thing which has to be where I would prefer not a senior to assist, but a junior to assist, so that the junior will keep quiet. That is the first tip I would like to give for all people who are delivering a floating head. From my experience, have an assistant who can wait and watch. Allow the fluid to drain very well. Look at the side of the back, and whoever is there can give the push from the side in which the back is there. If they start giving it from the side in which the limb buds are there, that is the problem. That is the end of it. The baby will turn to the other side. That is one thing that we have to prevent. And they say, I think 4 o'clock meeting, they are calling me. And she has mentioned all about it. I think nowadays people are little discouraging on forceps. They are more advocating on use of your accouchous hand in delivering this thing. And the incision, of course, has to be in such a way that you are well away from the uterine artery. Of course, deeply engaged head, whatever you have said is the best. And of course, reverse breech extraction is the one which I have been following in the last 4 decades. I never had an extension of the uterine tail because all the other things, initially I used to see my senior professors doing that and getting into problem. But after starting this reverse breech, put your hand and take out, that has really helped me. All the best, Sheila. I still imagine how you used to walk around with the sutures and the uterine module in your hand throughout this country and outside the country.
Thank you, ma'am.
Thank you,
ma'am.
Thank you, Sheila
Thank you so
Mane, madam.
much. Yeah. Dr. Aruna, ma'am, your comments.
Yeah. Thank you, Sheila Mane, madam. It was an excellent talk. You have given us good tips. And we still remember you as PPH lady. We still remember your PPH workshop at Usmania Medical College. It was excellent. That was the first PPH workshop we attended, and we followed, and we got so much of knowledge. Thank you for that. Thank you very much.
Thank you.
Yeah. And congratulations, Aruna ma'am, for your professorship from all of us.
Thank
so
you
we
so
move on to
much.
the next session, Rashmi. Dr. V.P. Paili is already here.
I invite coordinator Dr. Shalaka Bari to kindly conduct the next session.
A very good afternoon to all the dignitaries present here. Now we begin with the second session, and the chairperson for the second session are Dr. Preeti Kumar ma'am. Can I have the CV, please? Madam is the co-chair of Perinatal Committee, SAFOG, chairperson of Safe Motherhood Committee, FOXY. She is the director of Sunflower Medical Center, Lucknow. She has been the organizing secretary of AICOG Lucknow 20, Gestosis 2019, IAGE 2018, North Zone Yuva FOXY 2017. She was the vice president of Lucknow OBGY Society. She is a core member of Prevention of Violence Against Women Cell of FOXY. recipient of Padma Bhushan Kamlabai Hospital Award, recipient of Foxy Mr. P.A. Pandit and Mrs. Shailaja Pandit Award. She is a recipient of Foxy Imaging Science Award. She has received the Appreciation Award by Health Ministry for ensuring safe motherhood in UP year 2020. And she is a Society Liaison Officer, Foxy FIGO Project, UP, India. A second
Thank
chairperson,
you.
Dr.
Thank you so
Alka.
much.
Welcome, madam.
Thank you so much.
Yeah, welcome, ma'am. The second chairperson for today's session is Dr. Alka Mukherjee, ma'am. Can I have the CV? She's the president of NOJS 2021-22. She's a president-elect Narchi Nagpur chapter, honorary secretary of International Council for Human Rights. She's honorary secretary of ISOPARB in 2018-20. She's on board of Super Specialty GMC, IGMC, AIMS, Nagpur, NKP Salve Institute, ESIS, and treasurer of Nagpur for Vishaka Committee. She is a national executive member for Indian Medical Legal and Ethics Association, founder member of South Rapid Action Group, Nagpur, and organized various conferences as organizing secretary. Welcome, madam. Our third chairperson is Dr. Girish Mane. He's a past president of Yavatmal OBGY Society, past chairperson of Adolescent Society Gynecology Committee, and he has been awarded as a best chairperson for that. He's a recipient of Foxy Smriti Milan Save Baby Girl Runner-Up Award, recipient of Society Award MOX in 2016-17. He's a recipient of Duru Shah Youth Trophy and Dr. Sadhna Desai Award in 2017. He has won the first winner of a Foxy Talent Singing Contest. He has contributed 5 chapters in Foxy Focus, presented many papers in national and state conferences. He has been the editor of Foxy Focus Adolescent Intervention for Future Reproductive Health for Adolescent Healthcare and editor of Adolescent Health. Welcome, Mane. Over to chairpersons.
Thank you, madam. Thank you very much.
Thank you so much. So, hello everyone. Good afternoon. At the outset, let me congratulate the new team of ISOPARB Vidarbha chapter under leadership of Dr. Surekha Taide and Dr. Manisha Ghate. I'm indeed very happy to see the academic orientations and quality webinars, which we started in our tenure. They are getting more and more focused. Today's topic of making cesarean section safe is a live example of this. May I have CV of Dr. VP Pelli? Yeah. So it's my honor and privilege to introduce a doyen and navigator in the field of obstetrics and gynecology, Dr. VP Pelli. We all know quality needs no introduction. It speaks for itself. Renowned for his highly acclaimed skills, Dr. Pelli is a passionate teacher. The legendary figure, Dr. Pelli, is known for his skills all over the globe. Dr. Pelli, who will be talking on the placenta accreta spectrum, tackle the demon, is the senior consultant and head of department of OBGY. During his initial days, he was consultant and HOD at Dammam Maternity Hospital, Saudi Arabia till 1990. And later he joined Government Medical College, Thrissur, for a pretty long period of 8 years. And then he continued his professorship at Jubilee Mission Medical College. Today I understood why Kerala has the lowest maternal mortality rate all over India. Because when the visionary leaders like Dr. Pelli, who are so passionate for saving mothers, that he edited the book, The Obstetric Management Protocols, way back in 2001, and Why Mothers Die. In 1952, UK decided that the practicing clinicians should audit each other's maternal death, and that Kerala adopted this way to reduce the maternal deaths. Dr. Pelli is the most sought after speaker nationally and internationally, and he is very frequently visited by several celebrities, the aspiring models, and other honorable clients and international patients as well. The efficiency, the dedication, the precision, and the compassion and the personal touch of Dr. VP Pelli made him extremely popular among the patients and the peers equally. His love for technology, and specifically the new ones, diligence and carefulness, puts him in the rare category of neophile personality. His clinic is equipped with highly advanced surgical equipments. So all of you will share my thoughts that this person has a charismatic, magnetic personality whose presentations and videos, they are immediately received attention and likes are pouring in. So with these words, I welcome this innovative, calm, composed, legendary person, Dr. Pelli. Sir, the stage is all yours. Thank you so much.
Thank you very much. Thank you, Alka, Girish, Shalaka,
And of course, Surekha Tayade for giving me this opportunity to share our views on managing placenta accreta spectrum. And of course, the topic being difficult cesarean, I cannot imagine any more difficult situation than having to do a cesarean for a placenta accreta spectrum patient. So if I may be allowed to share my screen.
Yes, sir.
And again, as was mentioned earlier, there are different difficulties that come up when we do a cesarean, but the one with a placenta accreta spectrum, I think is the most challenging. And it's almost always a nightmare, especially if you have known that it is going to be a percreta. That's such a big nightmare for all of us. It's a killer if it is not properly managed. We in Kerala used to have about 5 maternal deaths every year, on the table deaths due to placenta accreta spectrum. And the number would have really gone up because our C-section rate unfortunately has gone up. And this is almost always a problem that occurs in a pregnancy that follows a cesarean section. But I'm glad to share with you the thought that in the last 10 years, there are only 17 maternal deaths due to placenta accreta spectrum. And of course, the near misses have gone up. And the reason for that, our converting maternal deaths to near misses was some of the developments, some of the innovations that we made on tackling this. And even before term, full term, scar pregnancies can play havoc. And that is why it's important to have a strategy to tackle when we have a placenta accreta spectrum as our problem. Almost always it occurs, as I said earlier, in a pregnancy that follows a cesarean section. And more the number of previous cesareans, more the chance of placenta being previa and that to accreta. What is the reason why it is such a catastrophe? It's very simple. It is the uncontrollable bleeding that may occur while trying to separate the bladder from the placenta. So most of the time, placenta accreta spectrum being a spectrum from accreta, increta to percreta, is the percreta that's the real killer. We can manage the accreta without much of an issue, and even the increta. But the percreta, where it has gone beyond the bounds of the uterus and invaded the bladder, or the parametrium, that's the problem. So we should have a way of reducing the blood supply to that area. And that is why we developed this aorta clamp, which we also call common iliac artery clamp. You can apply to either of them. Aorta clamp, if you are applying, only one clamp is required. Whereas if it is common iliac arteries, you have to apply on both sides. And a clamp is a very simple device. With a Babcock, you can pull up if this is the aorta, and then I will show you pictures of that. The clamp, you just apply it around like that. The novelty of this is, unlike the many other clamps that the vascular surgeons use, this is a simple instrument, looking almost like an Alice forceps. But please remember, these are not teeth. These are guards at the tip of them. And that is the magnified view of it. And when you close it, you can see that there's a gap between the two blades. This is to prevent crushing of the aorta, which will be there between the two. And there's a long ratchet. So this is what we developed. It has got smooth blades. There's a gap between the blades, a long ratchet, so you can compress to the extent that you need. And there's a guard at the tip. That is what you saw, which makes it look like an Alice, to prevent it from slipping while you are operating. And if I can show you this video, how we apply it. So you can see, the uterus is exteriorized. This is the posterior abdominal wall. That's the lumbar region. You get the bowels moved away from there. After you have retractors, you move the small bowels towards the right and the sigmoid towards the left. And there you can see the common iliac artery, the right one, common iliac artery, the left one. This is the lower end of the aorta, which you are lifting up with a Babcock. The Babcock goes the open position, catch the whole aorta with it, gently lift it up by 2 or 3 millimeters, not too much, and then bring the clamp in the open position, go in by the side of the Babcock, and then having got the clamp go beyond the aorta, just clamp it there. So that the entire thickness of the aorta is now within the 2 blades. And that cuts off blood supply beyond it. You can palpate the common iliac artery and confirm that there is no pulsation. But if it is not easily accessible, the aorta, you can actually put the clamps on both common iliac arteries, and that will stop the blood supply to the pelvis and, of course, the lower limbs.
Nipple and everything.
Now, this is a case where
problem, nipples and all. No,
we have
delivery feeding.
Sheila ma'am.
Yeah. Okay.
so you can see that this is a case of placenta accreta spectrum where we are using it on the common iliac arteries. A vertical incision. What you saw a little earlier was me putting the cannula or the catheter for the ureters, so that when we are doing the hysterectomy part, we will be sure as to where the ureters are. We can palpate it easily. Put your incision well above the level of the placenta. The level of the placenta, you know by previous ultrasound. Through a vertical incision, you have delivered the baby. Placenta is left undisturbed. The edges you can hold in an Alice or a green Armitage. And then after putting the placenta with the uterus outside towards the foot end of the woman or the patient, then you are exposing the common iliac artery at the pelvic brim, holding it up, just like the aorta here also, the common iliac artery is held up with a Babcock, and then with the full thickness is taken by the clamp. Here you have to put it on the right and the left. On the left side, you have to be a little more careful because the mesosigmoid also will be there. On both sides, the ureters may come over that. So you have to take care of this. And this particular case, this is an earlier case, we have been putting tunicae for the infundibulopelvic ligaments and then proceeding to do a hysterectomy. These days, we may consider more and more of the conservative surgery, but this is a percreta placenta. So you can see that is the part where the placenta is bulging. That's the surface of the protruded placenta, this one, and the bladder has been separated and pushed down. So you can put the clamp on both sides for the uterines, and having gone below the level of the placenta, you can approximate your fingers from behind and forward, front, and approximating it, making sure that you have gone below the level of the placenta, you are transecting that cervix, leaving part of the undilated cervix in the body. So in other words, we are doing a subtotal hysterectomy. That cervical stump we are palpating. We have to double check the stumps and making sure that there is no bleeder there. And this is the specimen that was got out. And this is the fundal area where the incision took the baby out. The placenta had come out, and this is just made a section, longitudinal section of that to show you how the placenta is. This is a specimen. The finger goes into the cervical canal, and that is the body of the uterus where the incision, and this is the placenta which had actually come out. More of the placenta out. More of the placenta out. As you can see, so much of the placenta had come out. And you can see that there's a thin coagulum on the surface of it. If you break it, then you can see the placental villi projecting outside. So this is the thin coagulum that helps it contained. That is again another case, but not as bad as the previous ones. Again, you can see the thinned out area here, but this is a percreta. If the serosa is still there, it is a percreta. You can see another case of percreta. That's the finger in the cervical canal, and that the whole lower segment with the placenta which had come out. So these are a few examples of what can happen in a case of placenta percreta. And that is the most difficult one of the three. It is important to remove the placenta, entire placenta. And if you don't remove the entire placenta, even a small bit left behind can lead to what you are seeing here. It's a patient sent to us from the periphery, and the whole abdomen filled with blood. Mother with a heart rate of 170, papery white. And of course, we could save her, but so much blood was there. And if you watch us removing the whatever was left behind by the previous surgeon, see, at that point, so much blood was there. And that is actually what we can see here. That is the intact cervix, the external the lip of the cervix, and only that much of placenta was left behind. And just because of that, the mother almost bled to death. So that is why I feel that it's important to remove the entire placenta, but you have no reason to go and remove beyond that, because that removal is the most difficult one. That is the area where the bladder is stuck to the cervix, and you try to separate them, more bleeding provoked, deep in the pelvis, difficult to tackle. So my recommendation usually is that don't try to remove the cervical undilated cervix. Only that part which is there just below the placenta, at that level you can transect and remove it. Please remember, a subtotal. If the patient is not in labor, a subtotal is enough, but make sure the entire placenta is removed. That's the point. Here, I'm just showing you another clip, one of my earliest surgeries where before these clamps were developed, as you can see here, again, another case where you can see that that is the whole placenta which had come out. This gelatinous coating on the surface of it, as the whole placenta was percreta. You can see the big vessels over there. And I thought, this is before we developed the clamp, while working towards the thinking of various ideas how to tackle this, I thought, why not go and clamp the internal iliac arteries or ligate the internal iliac arteries before we touch the uterus and the placenta. That is what we did. And in spite of that, in spite of having the bilateral internal iliac ligation, as I was going down towards the uterine artery area, you can see so much bleeding over there, and the bleeding became unmanageable. So we had to somehow go and get, in panic, remove the uterus with the placenta. In that process, the bladder got injured, and she had to have repeated attempts at correction of that. And you can see that this was the specimen. The whole placenta had actually come out. And internal iliac artery ligation alone is not enough to tackle such problems. That is when we developed clamps to occlude the common iliac arteries. The problem with the internal iliac artery is that after the internal iliac artery takes off, from the external iliac artery, the inferior epigastric artery, which goes to the anterior abdominal wall. And from there, over the dome of the bladder, blood will come and the vessels will come and anastomose with the surface vessels on the placenta. So even if you occlude the internal iliac artery, the inferior epigastric will continue to supply. And that is why we reasoned out that common iliac will be a better vessel to tackle than the internal iliac. And that is when we developed this clamp. For developing the clamp also, the vascular surgeons do the cross clamping. For example, if this is the aorta, they have to have one blade go under the other blade. To have the blade go under, you have to isolate the aorta, one blade inside, underneath, the other above, and then put the clamp like that, cross clamping. And that's the problem. If you try to dissect and isolate the aorta, separate it from the nearing big veins, and try to put a cross clamping, there's always the risk of injury to these veins, and it is not within us. You have to depend on a vascular surgeon for that. I wanted to develop a clamp which can be applied by a reasonably experienced obstetrician doing the cesarean. And that is why this clamp was developed, which doesn't need to isolate the aorta by dissecting around it. You just pull it up and apply the clamp. That made all the difference, the outcome that we had. And this is a case, again, a difficult one because so much of the placenta had come out, and separating the bladder from the protruded placenta was the problem. No planes here because the placenta has invaded the bladder. And that is why, but because of the clamp in situ, we can see that bleeding was manageable So we could separate just to demonstrate how we separate it, we have to identify the plane between the placental surface and the bladder. It always has to be done very delicately because we can very easily get into the bladder cavity. And there are many people who say that, okay, it doesn't matter, you excise that part of the bladder. Not as simple as that, because the part that is invaded can be very close to the trigone or the trigone itself. And you cannot easily take away that part. If it is the dome of the bladder, fine, we can take away some part. But the trigonal area, you cannot. And there is the damage and there is the more amount of bleeding. So whenever possible, we try to coagulate and tie those bridging vessels from the bladder towards the placenta. This is the whole uterine body over here. This is the incision through which the baby was taken. This is the anterior surface. And you can see the plane being developed painstakingly so that the placenta, its coagulum on the surface is not disturbed. The moment you disturb that, she will start to pour from that area. So slowly we are dissecting, separate. You can see the bulging. When the finger is taken away, what is bulging is the placenta. And this is the whole bladder, which is being separated from the uterus. And having got the bladder separated completely, taking care of the bridging vessels, then it is thereafter just proceed with a subtotal hysterectomy. So that is how we tackle the placenta percreta these days. So you can see that that's the placenta still there and then taken out. So clamping the aorta is time sensitive. We cannot just clamp it for any length of time. You have to be sensitive to it. Usually we used to say that maybe for 40, 50 minutes at the moment. But of course, we have had recently cases, so difficult cases, we had to even clamp it for even 2 hours. And post-operatively, we give them low molecular weight heparin, and we have not had any issues. This is what I'm talking about is a collective experience of obstetricians in different centers in Kerala, where they use the aorta clamp or the coronary artery. We do not recommend to release the clamp in between so that the viscera become, get some blood supply in between, because at that time there can be profuse bleeding. And thromboprophylaxis postoperatively is important. As we can see here, where we actually thought that we have completed, but then on releasing the clamp, you see how much of blood is there. We cannot identify where the bleeding is coming from. This is all the uterus is already removed, but it is the bladder base which is bleeding, and holding the bladder with the Babcock and then trying to identify those bleeders and coagulate or tie them turned out to be impossible because we had already released the clamp. So we decided that we have to go back and apply the clamp again, and then the Babcock is brought back and the clamp is applied again. And then when the pooled blood is sucked out, you can see that we have a dry field and we could proceed with the surgery. Identifying the bladder-based vessels, tying them or coagulating them and proceeding. So the difference that it makes when you have the clamp on and the clamp off. This is a typical example where we had done the hysterectomy part, but it was the bladder base which was starting to bleed like that. So we have more than, this was 100 a few years ago, and now it is anything about 200 cases in the centers where the clamps are being used, and there has been no maternal death from that. Blood transfusion requirements came down considerably after we started to use. That's the seen in this example from another medical college, Kottayam, in the middle of Kerala, where before the new strategy of using the clamp, 20 cases, average blood requirement was 11.5 units. But after the clamp started to be used, it came down to 1.5 units. My colleague in Kottayam, Kunyama Roy, gave me this data. So conclusion, my dear friends, it's important in cases of placenta accreta spectrum, it's important to diagnose early. And for that, we have made a rule in our state that Every pregnancy following a cesarean section should have a dedicated scan at 32 weeks, with a request given to the radiologist or the sonologist saying that please check for the placenta whether it's a previa and whether it's accreta. Otherwise, they will say baby is fine, BPD is like that and all that. Ask to locate the placenta and tell us whether it's a accreta. And if it is reported, or even if they say it is not so, if the placenta is in the lower segment in a previous cesarean, expect the possibility of an accreta. And be prepared to control the blood flow to the uterus by use of a clamp like this. I usually keep a urologist on standby, even though some degree of bladder laceration and all that, we can tackle ourselves. If it's an extensive laceration, we may request our urology colleagues to come and help us. Hemostasis should be achieved before closing the abdomen after releasing the clamp. Make sure the bladder base, that's the site where the bleeding is usually, reactionary bleeding is maximum from the bladder base. So make sure that you doubly check it, and also the stumps also are double checked. And you leave a drain before you come out. Thank you. So these are some of the tips for tackling the placenta accreta spectrum patients, which unfortunately in our state, of course, very high because our state average C-section rate is 40%. In other parts of the country, it is more, but there are many areas which is not so much. Wherever it is, it's a pregnancy following a cesarean, think of this possibility. Thank you very much. Thank you, Sireka, for this opportunity.
Thank you, sir.
Thank
Dr.
you very
Preeti,
much.
please, she has to go.
Thank you. Thank you so much.
Thank you, sir.
Girish,
Thank you very much.
Thank you, sir.
Dr.
Girish,
BP Pelly,
Dr.
sir.
Yeah,
Preeti has to go.
I want to say something to sir. May I please?
Yes.
Yeah, please.
Yeah, thank you very much, sir. It was really a wonderful and very hopeful presentation by you. As we all know that not only in your state, but almost in every state, the rate of cesarean section that is increasing. And definitely that's why the cases of increta, percreta, and all type of these cases, they are increasing day by day. And I should congratulate you for your aortic clamp, which is reducing the need of this blood transfusion from 11.5 to only 1 beat. It's really amazing and incredible. I was just a little bit, curious about the need of this total hysterectomy versus subtotal hysterectomy. But as you already mentioned, that subtotal hysterectomy should be preferred one. And the tips which you have given, that your center should be appropriately equipped, the arrangements for anesthesia, the need of ICU, and especially the availability of the surgeon, and that to be the bladder surgeon, the urologist, that should be there always, because sometimes you may not get help from your friend who is not nearby to you. So their presence while doing the surgery is really must. Then availability of the ampoule of blood, then the availability of the instrument like aortic clamp, they are really needful. And the most important thing, what I feel, the new people, whatever theoretical knowledge they have, they shouldn't try such kind of cases without the assistance of the people like Sir or Surekha Madam or Preeti Di. So at least 5 cases should be handled with the stalwarts who are expert in such kind of cases. And as Sir has told that he has handled more than 100 cases, but not a single maternal death. We may, the new person may lose their patients while handling such kind of cases. So thank you very much, sir. Thank you very much. Over to you, Preeti ma'am.
Thank you, Girish. Thank you, Dr. VP Pelly, sir. We feel really privileged and honored to chair your session, sir. Thank you. It's always, we look forward for your presentation, and we just, when your presentation stops, we say why you have stopped the presentation. Your presentation should continue like anything. So we learn so much from your presentation. So one question, how long you give low molecular weight heparin in these patients? It's for 7 days or 10 days?
No, not really. Usually we give them the day after the surgery, and then 1 or 2 days only. By the time they are ambulant, and once they are ambulant, we stop giving. Of course, we continue to give them the stockings and ask them to be ambulant. If they are not able to be ambulant, for example, if you had difficult surgery and lot of blood loss and all that, maybe continue for 2 or 3 days, not 10 days and all that. We usually do for maybe 1 or 2 days only.
Days, okay. So thank you so much, sir. I don't think in UP this side anybody is using this VP Pelly clamp, sir, because we are not that confident in using. We usually proceed on with the internal iliac ligation and then hysterectomy if needed. Sir, in your experience, I would like to ask you, what complications did you face? Because you have lot of experience in aortic clamp and even common iliac vessel clamp. What are your experiences? How many complications did you face in this, sir?
Thank you, Preeti. The point is, as I said in my introduction, why this clamp was developed was that it should be applied by a, say, middle level obstetrician. That's how I developed it. So all that you require is no dissection on the aorta. Many people think that aorta has to be dissected and lifted up. The video I showed was not a dissected one. It was a thin patient. That is why there was no fat on top of the aorta. If there's an obese patient, you may have some fat on top of the aorta. You palpate the aorta. If you cannot see it pulsating, palpate it and go with a Babcock like this and open it and go down and then gently lift it up. Then apply it. Now, thank God, we have now used it in probably more than 200 cases in the state. There was no case of injury to the aorta or to the inferior vena cava or the common iliac vein. So none of the cases we had. And that is why we feel bold enough to promote it. But of course, it's important that you should have proper access to the lower end of the aorta. If you don't have it, don't try to struggle there. Go to the common iliac arteries, which are probably safer. Only difficulty is you have to, on the left side, there is the mesosigmoid. And on both sides, you know, the ureters are crossing. But once you have that much of experience of being, say, 5 or 10 years as an obstetric surgeon, then you will be able to identify where the ureter is. Now, the other thing is, even if you clamp the ureter, yes, no harm, because it is not a naked ureter you are clamping with other tissues. So that is why I feel that this is useful for the practicing obstetricians.
Okay, sir. Thank you so much, sir. Thank you so much for the wonderful presentation. And we really learned a lot. I think I've seen your presentation several times, but somehow we really are very scared of applying aortic clamps. We usually do the iliac ligation hysterectomy. This is our common practice here.
Those who can ligate the internal iliac.
Yes, sir.
It's so much simpler to do than
Yes,
internal iliac ligation, which can be quite challenging in some situations.
So we'd definitely like to, because Mitra is also here and Surekha is very active. So from Safe Motherhood Committee, Practical Obstetric Committee, and with Surekha, we would like to have some workshops on aortic clamp for these. This would be very useful for the OBGYNs, especially for the young OBGYNs. Thank you so much, sir. Thank you so much.
And sir, thank you so much. A few questions are there in the chat box and from my side also. Sir, regarding the size of the clamps, the aortic clamp and the common iliac clamp, are they different sizes, sir?
No, same clamp. Same clamp.
Okay.
Same clamp is used.
Yeah. The host has muted me. Please don't mute me. And I think there are a few more questions in the chat box. Dr. Bangal wants to ask some question. Sir?
Yeah, sure. Please go ahead. Can I leave so that you can?
Does aortic clamp completely stop the flow?
Sorry.
How much is the reduction in the blood flow distally after aortic clamping?
No, we actually feel that there is no pulsation in the common iliac artery. That doesn't mean that there is absolutely no blood supply to the area of our interest, that is the lower segment or the bladder base, because they still draw blood from the collaterals coming from other sources. But what is important is the moment you apply the clamps, the pulse pressure comes down. That's it. It is not that the area is made totally avascular or ischemic. There is no ischemia completely because there is still blood supply to that. If you happen to break the surface coagulum on the placenta, she will continue to well up. So there is still blood supply, but the common iliac pulsation will stop if you apply it. And that way the pulse pressure comes down, and that is how the principle of its action.
My second question is, recently I got one patient, 22 weeks, previous seizure, placenta accreta. How do we predict her invasion? And what actions can be taken now?
She is 22 weeks. And the question immediately comes whether we should continue the pregnancy or get it terminated at this point. I would try to go, because she has already gone to 22 weeks, try to see whether we can continue the pregnancy till to get a viable baby, maybe not up to 36 weeks. Most of our patients we deliver between 34 and 36 weeks. So I will try to see whether we can carry it till 34 weeks. And at that time, with all the precautions I mentioned, deliver her with consent for a hysterectomy if required. If it is just a scar pregnancy, need not always be a percreta. It can still be an ingreta, in which case it may not be a big issue at all. That is why, just because it's a scar implantation, I don't insist on terminate the pregnancy at that point. But you can have an idea how bad it is going to be even from early stages. The ones which are likely to be really percreta may already have a very thin layer between the placenta and the bladder, in which case they may warn you that she's likely to present problems. In which case, before say 14 weeks, if you get it, we may give mifepristone and then probably get a pregnancy terminated with, again, warning that that can have difficult bleeding even in 12 weeks or 10 weeks pregnancy, which is scar ectopic. But beyond 20 weeks and all that, I may try to or agree to continue the pregnancy to get a live baby, and then with the consent that she may end up in a hysterectomy.
After 20 weeks, how frequently we should do imaging to follow?
Actually, it doesn't have to be very frequent. I would probably use one at 28 weeks to get a better idea, and 32 weeks, that's the last one. That is the one that will plan our surgery. And unlike what the literature and other people say, most of our patients get an MRI scan also. Because the advantage I find is that it is easier for us to identify in a graphic way where exactly is the maximum invasion and how much it is and all that, unlike pictures that we get from the ultrasound. Ultrasound moving pictures, the main advantage is that gives you a better idea about the vascularity. MRI, the advantage is better to get the invasion. And of course, it's a posterior placenta previa coming anteriorly and invading the scar area is a real problem, because they draw blood, they come from the posterior wall coming anteriorly. The supply to the uterus through the uterosacrals, collaterals from the posterior pelvic wall and the lumbar, which may not be blocked by even an aorta blocking, will be a real problem. So just because we block the lower end of the aorta, we shouldn't expect that you get a totally avascular field for surgery.
Sir, absolutely fantastic. Yeah,
Sir, have you experienced any case where you could remove the whole placenta in the diagnosed case of placenta accreta or percreta and save the uterus? Is it possible? Or shall we go for in every case for hysterectomy only?
No, actually depends on how bad the invasion beyond the bounds of the uterus is. If it is anything short of a percreta, we can save by even segmental resection. Whereas if it's a percreta, we have to be a little more careful, because the problem here is not only the bleeding, but the invasion to the viscera, especially the bladder. If you are able to separate the bladder completely, then you should be able to take a wedge of that area, including probably sometimes the uterine wall of that area, and reconstruct it. Most of the time we had been all along doing a sort of a radical approach where we are more in for a hysterectomy, because in the Kerala culture, most of them, we get it usually in the second pregnancy. Many of them, even without this problem, are prepared to stop with 2 pregnancies. And when they have an accreta situation like this, they are quite willing to, even stop further pregnancies. So we had the pressure to save the uterus for a future pregnancy was not much. But now, because of the international accrued knowledge on conserving the uterus, we are also going to try to see whether we can save more of the uterus. But personally, I feel that, unlike the triple P procedure of Chandraharan, personally, I feel that I will leave a uterus behind if the woman wants further pregnancies, rather than just because she wants the uterus for menstruation.
For example, sir, sometimes even the primary or a second grada without any live baby, I mean, such kind of cases can be there, and they may pressurize this one, So
Sure,
just I want to know whether you have any experience or not.
We had conserved uterus, and our own experience, as I said, for these are not that extensive. But if you look at the Argentinian experience, or even the London, St. George's experience, they all claim to retain the uterus for future childbearing by segmental resection. And in somebody who wants further children, unless it is a badly perforated placenta, you may be able to save the uterus.
Thank you, sir.
Sir, any role of embolization?
Oh, I mean, that is another way, but that, remember, we can do that only after the baby is removed. So you need to have the facilities for interventional radiology when you think about either a balloon or an embolization. Embolization may become handy. Sometimes, even after hysterectomy, there can be unmanageable bleeding from the bladder base. In which case, embolization may be needed. But I don't.
मैं करवा लेती हूँ. हाँ. Sir, Dr. Uday would like to say something because he was not there for the inaugural part. So I now request Dr. Uday for his guidance for this webinar.
Hi, Uday.
Yes, sorry, sir. It was a great discussion going on. I saw half of your presentation. It was absolutely wonderful, like always, and good to see you, sir. And congratulations, Shureka, for such a lovely program. And over here, people like Sheila and all, it must have been a lovely afternoon. Everybody gaining a lot of knowledge. And over here, let me also invite you all to the ICOG annual conference, which we are hosting in April 22nd, 23rd, and 24th of April. It's going to be a physical conference in Vashi. And we have stalwarts like Dr. Mitra Saxena and hosting the Practical Obstetric Committee workshop, or the Practical Obstetric workshop, in which we are going to deal with, she's going to teach everybody internal iliac, and she's told me I'm going to do it differently, and it's going to be a 3 to 3.5 hour session only on internal iliac dilation. So let me push this, my agenda over here, to invite you all for the conference, and I'm going to rope in Dr. Paili also for that, so I will get in touch with him. I have yet to, we started making the program last week when we got the news that our dates are going to remain the same in April, in spite of AICOG being shunted. So, and I think it's a good thing, because hopefully there will be no COVID at that time and you can travel in April. So I look forward to welcoming all of you to Navi Mumbai in April. And with that, all the best to you for this lovely webinar. I'll join in after some time. Thank you very much.
Thank you. Thank you so much, sir. And I request Rashmi to go to the next session.
So let's move.
Thank you, everybody.
Thank you, Sureka. Thank you so much. Thank you, sir.
Thank you, respected speaker and chairpersons. Let's move on to session 3. The third session is Code Blue, Massive Obstetric Hemorrhage during LSCS. And speaker is Dr. Pushpa Somanshi Madam. And the chairpersons are Dr. Vaidehi Marathe, Dr. Vidarbha Bangal sir, and Dr. Anil Rathod. Dr. Vaidehi Marathe, I think she has some other commitments, so she had joined and left. I would like to introduce Dr. Bangal sir. Nisha, please slide. Dr. B.B. Bangal sir is professor and HOD, OBGY, DBPP Rural Medical College and Pravara Institute of Medical Sciences. He is the most respected PG teacher and PhD guide. And at present, he is president, Lowering Obstetrics and Gynecological Society. Our next chairperson is Dr. Anil Rathod. He is a dynamic young obstetrician and gynecologist from USAD Society, and he has recently joined ISOPARB Vidarbha chapter. I would like to request Dr. Manisha Ghate, also, who is secretary and dynamic OBGYN from Chandrapur, to kindly chair this session. Dr. Manisha Ghate. Over to the chairpersons.
Thank you, Rashmi. Can I have CV of respected Pushpa Madam?
Just a minute.
Request everyone to be brief with the introductions, please.
Yes. Good evening, one and all. I am highly privileged and to introduce my teacher par excellence, Dr. Pushpa Zungare Madam. Madam is affiliated member of UG and PG Board of Studies of Surgery and Allied Subject. She is faculty in many national, state and zonal conference. She is the past president of Amravati OBGY Society, organizing secretary State Conference of AMOX in 2005 and organizing chairperson for AMOX in 2020 at Amravati. She had many achievements and awards. She has popularized NDVH in Amravati region and instrumental in establishing first human milk bank in central India at PDMC Amravati. She has received Amravati District Best ICTC Award 2014-15. And with this, I request my teacher, Dr. Pushpa Zungare Madam, to take over. Madam, please.
Share my screen.
Yes.
I don't know. I'm not able to share it.
Ma'am, you have to click at the bottom.
Share screen.
Madam, is your presentation open on your desktop?
Not open, but it is on the desk.
Okay. Just open the presentation first. You can minimize the Zoom. Open your presentation. And then share screen. If you want, I can share your presentation.
Nisha can share.
No, yes. I'm sharing. Is it visible now?
Yes, ma'am, it is visible.
Ma'am, once do it full screen. Yeah, yes.
It's visible.
It is visible.
Okay. Good afternoon to all of you. After such a wonderful presentations by Dr. Sheila Madam and Dr. Paili sir, we have witnessed what problems we can have during cesarean section. Many of the problems they are going to be discussed in the panel discussion. But one problem which can give you goosebumps, or in which we have to operate code blue, is massive obstetric hemorrhage during LSCS. It is a medical emergency. That is, you just can't predict what is going to happen. Unpredictable. The name is obstetrics. You all know this very well, and almost all of you must have experienced the perils of practicing obstetrician. And this is the precise reason why we should be predictable. Predictable in the sense that we should be prepared to handle any of the obstetric complications. So expect the most unexpected things. Now, when you are doing Caesar, you have opened the patient, taken out the baby, placenta has started separating, but now the patient starts to bleed. Your field is full of blood. So from where she is bleeding? Bleeding from the incision, or from the extension of the incision into the uterines, or from the placental side. You suck out the blood, identify the bleeders, and quickly catch them with the Ellis tissue forceps. If the uterine vessels are injured, catch them with green Armitage forceps or artery forceps. If the placenta is only partially separated, you better expedite its delivery by controlled cord traction. In cesarean section, the fastest step should be to close the uterus. This will take care of the bleeding from the incision. And even if the bleeding is from the placental side, it will be reduced only when the uterus contracts. And mind well, only a closed and intact uterus can contract well, and bleeding from the placental side surface can be reduced by bringing into action the living ligages. Now, whenever we come across severe bleeding during seizure, by rapidly closing the uterus, the bleeding from the incision can be reduced. But what about the bleeding from the injured vessels or the vertical extension of the LSCS wound, either into the upper segment or into the lower segment, or there might be lateral extension into the broad ligaments? What about bleeding from them? Or there can be bleeding from the placental side because of uterine atony. So what is to be done? So there are two options. One is internal iliac artery ligation or obstetric hysterectomy. We'll see this one by one. In internal iliac artery ligation, it is an emergency procedure, as are many obstetric procedures. Most commonly, it is indicated for postpartum hemorrhage, mainly atonic and sometimes traumatic. Main blood supply to the uterus is from the uterine artery, which arises from the internal iliac artery in most of the cases. In atonic postpartum hemorrhage, after the medical treatment fails to control bleeding, the alternatives are to remove the source of bleeding, that is the uterus, or to hamper its blood supply by various means so that the organ can be saved. Ligation of internal iliac artery appears to reduce pulse pressure approximately by 85%. This converts the arterial circulation to venous type, thereby slowing the blood flow and bringing about coagulation of the blood. Although this operation is frequently advocated, it is potentially dangerous unless the surgeon has operative experience in the retroperitoneal space. The principal risk of this procedure are damage to the iliac veins or ligation of the external or rarely the common iliac artery, which would compromise blood flow to the lower limb, and it will be dangerous. Hence, it is important to get trained in this procedure while we are learning cesarean section or during hysterectomies by abdominal route. Now, what exactly is done when we are carrying out internal iliac ligation? This peritoneum is open parallel to the course of ureter. The ureter, with its blood supply intact in the peritoneum covering the ureter, it is reflected medially to expose the site of common iliac artery and veins. Common iliac artery, external iliac, and internal iliac arteries are then identified. About 2 centimeters below the origin of internal iliac, the anterior division of this artery is separated from the surrounding fascia so as to pick it up with the forceps or clamp without injuring the vein. Now, this is a graphical picture of this internal iliac artery ligation. So after dissecting the anterior branch of the internal iliac, the clamp is insinuated from lateral to medial side for ligation, and number 0 vicryl or silk suture, it can be used to ligate it. Thereafter, we have to confirm the pulsations of external iliac artery so that we are sure that we have not by mistake ligated the external iliac artery. Then the procedure is repeated on the other side. Even if we carry out this procedure on one side, still it is quite helpful. That is, if not by 85%, by 50%, the pulse pressure is reduced. This is the actual way in which we are going from lateral to medial side. And then we have to put the suture in between these two jaws of the clamp. There was an animated video. I was not able to open this right now. But what we have to remember is, that is, once you have skeletonized this anterior division of the internal iliac vessel, you have to always remember that always go from lateral to medial side. This will prevent injury to the iliac vein. Injuring iliac vein might be dangerous. That is, only vascular surgeon then will be able to suture the vein, and then it will be very messy. And the whole purpose of reducing the blood supply to the operative field, it will be defeated. So this is one alternative whenever we are facing with the open. I've taken this from this advanced practice strategies. So this is just an animated video. So first, you have to take the uterus anteriorly. You have to identify all the structures surrounding this iliac fossa. Uterus and bladder, they are pushed anteriorly. Then fold running by the side of round ligament. You have to take incision. By lifting the peritoneum, choosing a avascular area, we have to give an incision. And then with the fold attached to the ureter, ureter is taken on the medial side with the help of Babcock's forceps. And then we have to expose this iliac fossa. We have to identify this anterior division of the internal iliac artery. This is something what we are not supposed to do. That is, never go from medial to lateral side. Always remember this, that we have to go from lateral to medial side with the help of mixture clamp. Mixture clamp should always be in your drum, always be present on your trolley. And then a silk suture or vicryl number 0 is passed and the ligature is put in place. The other alternative is obstetric hysterectomy. It is an alternative method to tackle the complications of massive obstetric hemorrhage. Hysterectomy is considered as a last resort, but there are times when the last resort is most practicable to tackle the emergency. Hence, everyone should be well versed in obstetric hysterectomy. The indications of obstetric hysterectomy are atonic PPH not responding to medical line of treatment, ruptured uterus which is beyond repair, morbidly adherent placenta. Lot of useful things have been told by Dr. Piley about this. Then when the operating surgeon, this is an important thing, when the operating surgeon is not well versed in internal iliac ligation and other devascularizing procedure. Again, I will say that as Dr. Piley has said, applying aortic clamp or applying clamps on the common iliac arteries, he said there it is simpler to do this rather than carrying out internal iliac ligation. So that is why it is not always possible that the operating surgeon is able to carry out this procedure of ligation of the artery. But most of us, we are doing cesarean section, we are doing hysterectomy. So doing hysterectomy might be easier for that operating surgeon in emergency. About hysterectomy, timely decision is of great importance. Now, if whenever there is delay, that is, we think whether the obstetric career will be hampered or whether hysterectomy is going to help, or should we wait for more drugs to be given, or we carry out this ligation of uterine arteries, ovarian arteries, decompression sutures, internal iliac artery, and we are wasting time in that. In that case, the patient is likely to become more moribund, or she might have already landed in DIC, and then this problem will be worsened, and delay in hysterectomy might in fact accelerate the death of the patient. So taking decision at proper time, decision to remove the uterus, that is a very important thing to remember. Performance of hysterectomy and patients is different in a pregnant patient is different from that of gynecological hysterectomy in several ways. The blood vessels supplying the uterus, they are greatly enlarged. Collateral vessels which are not noticeable in non-pregnant state, they are numerous and they are prominent when the patient is pregnant. That is, even if the uterus is now emptied of uterus, this baby and placenta. Hematomas can result from transfixing sutures passing directly through the blood vessels. So we have to be careful regarding this when we are taking pricks in the pedicles. Pedicle clamp should be supported, not manipulated during the passage of the sutures. And one should be aware of the location of the ureters at different phases of the operation. A rapid control of the blood supply to the uterus is essential in all peripartum hysterectomy techniques. This is accomplished by clamping each individual vascular pedicle and quickly proceeding to the next pedicle. That is, instead of clamping, cutting, ligating one after the other, it is better to clamp all the vascular pedicles at a time, cut them, and then one by one we can suture them. Hemostasis must be meticulous. We can apply extra clamps to avoid backbleeding. In this postpartum uterus, the pedicles are expected to be thick, they are more edematous, and they must be transfixed. That is, transfixing sutures, they are better than simple ligatures. Two straight or curved long clamps can be applied on either side of the uterus to take care of backbleeding. The round ligaments are then clamped, cut, and ligated on either side. The UV fold is then opened. Bladder is pushed down. Posterior fold of the peritoneum also is opened. And then clamps are applied to the two tubo-ovarian, the uterines on either side. And then all the pedicles are cut one after the other. So instead of cutting each pedicle and then transfixing it, all these 4 clamps are applied. And then we go ahead with cutting and suturing. After that, descending cervical branches are also clamped, cut, and ligated because they are also a source of quite profuse bleeding. Subtotal hysterectomy usually saves the time, but sometimes it does not serve the purpose. So total hysterectomy is preferred in such cases. Like, for example, the laceration has gone over the lower uterine segment towards the cervix. In that case, we have to resort to total hysterectomy. Then all the clamps then they are replaced by transfixation sutures. Total hysterectomy, as I've told you, is recommended in case when the bleeding is from the lower part of the uterus towards the cervix. Like the incision itself might have extended into the cervix. In such cases, total hysterectomy has to be carried out. After this, vascular clamps are applied on the cardinal ligaments, uterosacral ligaments, and cut, and then we transfix them. Next, cut open the vagina to deliver the uterus along with the cervix. It is very difficult to learn the technique, this obstetric hysterectomy technique, or to make this operation quick and safe in emergency condition. So the teaching of basic concepts and techniques of peripartum hysterectomy to all obstetric residents should be encouraged under non-emergency conditions. And peripartum hysterectomy should be in the repertory of all consultant obstetricians. It is definitely a life-saving procedure, and one should learn it. Now, how to decide whether in this particular patient who is in pool of blood, whether internal iliac ligation is a better option than obstetric hysterectomy or vice versa. Now there are many factors which are influencing this decision. For example, experience and expertise of the operating obstetrician. Now, this might the operating surgeon might be a obstetrician running his or her own nursing home. Maybe the assistant doctor also is an obstetrician. But this complication of this emergency might arise out of blue. So whether that person is having experience enough or expertise enough to carry out internal iliac ligation or obstetric hysterectomy. So that will influence the decision. And if he or she is not well versed with this, either of these two procedures, whether experienced and expert obstetrician will be available at short notice in such an emergency. This also might decide the decision. One more important thing is obstetric history of the patient, whether she is a woman who is not having any living issue, or she might be a second gravida, already having one child, and now this child also is all right. So in such cases, multis or at least patient having at least one child, it is easier to decide. We can have inclination towards removing the uterus that is the source of bleeding instead of going for all this complicated other procedures. So obstetric history is a very much deciding factor. Naturally, if she is a primary gravida, or if she might be a patient of previous cesarean section, the first baby may not be alive, and this baby also is preterm. We are not sure about the survival or prognosis of the second baby. Then it is really difficult to remove the uterus. So that also has to be taken into consideration. Then whether the bleeding is because of atonic PPH or it is because of trauma. If it is because of trauma, then whether that trauma is repairable or it is beyond repair. So many factors, they have to be taken into consideration before we can decide which method is superior or which procedure we should resort to. As I've told you, whenever we think of removing the uterus, the decision should be timely. Suppose you think that we want to save the uterus and we go ahead with decompression sutures, we ligate the uterine arteries, ligate the ovarian arteries, then go ahead with internal iliac ligation. And then we notice that nothing is helping. And then we go ahead with obstetric hysterectomy. So here, retrospectively, we might think that doing obstetric hysterectomy would have been much better. It would have reduced the morbidity and saved a lot of blood. So the requirement of blood transfusion also is reduced. And more important, that obstetric hysterectomy will be useful if it is carried out in time, before the patient becomes anoxic, hypoxic, and she might land in then DIC. So with this added complications, lot of wasted time, retrospectively, sometimes we think that we would have gone ahead with hysterectomy much earlier. So this, to decide whether to do internal iliac ligation or obstetric hysterectomy, sometimes it is really difficult. But carrying out internal iliac ligation and then carrying out hysterectomy, it is definitely not going to improve or to reduce the blood loss, nor it is going to improve the final outcome. So if hysterectomy is needed, there is no need to carry out this ligation of various arteries. You straight away go ahead with obstetric hysterectomy. So earlier you do it, better is the chance that the morbidity will be reduced and less blood transfusion will be required. So I thank you all for your patient listening.
Dr. Bangal, sir.
I take this opportunity for seeking your blessings and best wishes so that I can serve Foxy in capacity of Chairperson of Medical Education Committee. Thank you.
Thank you, Madam, for a wonderful presentation.
Please stop share, ma'am.
Thank you for highlighting on two aspects, whether to do internal iliac ligation or obstetric hysterectomy, and when to do that. Time is very, very crucial when we all have experienced these occasions where time decides the outcome. And I fully agree that we should not waste time for doing conservative treatment when we predict that ultimately it's not going to help, with our experience, of course. And one who is there on table is the best person to decide on this. And of course, sometimes in a panic situation, we forget certain practical aspects like just aortic compression rather than clamping. If we are little worried about clamping, aortic compression can very well give maybe almost similar effect for whatever little time that we need during preparing ourselves and getting assistance. So thank you very much for highlighting on these two aspects, and thank you organizers for inviting me to be chairperson for this session.
Dr. Anil Rathod is there. Your comments, sir?
Yes, madam. It was very good presentation. Ma'am, I want to ask one question. In periphery like us, our area, if there is no that clamp. Hello.
Yes, sir. You're audible.
Yes, yes. Can we ligate the internal iliac artery by the simple long arteries?
I think holding the large vessels, aorta or common iliac with simple arteries, they might cause trauma. If you have seen carefully, Dr. Piley, he demonstrated the clamps.
Yeah.
They were smooth inside. That is, they were avascular, that is vascular clamps used for vascular surgery to hold vessels.
Madam, I
And
think
the
he's
lock or
asking
the-
about the mixtures which may not be there with him, and probably he wants to use a long artery forceps to pull the suture material beneath the internal iliac. Is that what you want to ask, Dr. Anil?
Yes,
if the
madam.
mixtures forceps is not available, can a long artery be replaced, be used instead of that?
Yes, yes. In emergencies,
Yeah.
No, long artery may be useful, but if it is angulated, it is better. And it is better, I would advise that everyone who is practicing obstetrics should have one mixture clamp in their
Correct.
Yeah,
Can I say
drum,
something,
readily
Surekha?
available.
Sureka,
Yes.
can I say something to clarify this?
Yeah.
Yes, ma'am, please.
Yeah. Dr. Anil, actually, as Dr. Pushpa says, mixtures are not difficult to get. I'm sure you'll be able to procure and keep. The reason why anything other than mixture, like the curved artery also cannot be used is because of the critical issue of the vein being very close to the artery there. So the internal iliac vein is, so very close to the artery, and we need to have something at right angles to go between the two vessels. If we use something less than that, it can injure the vein. It's very recommended that it should go, at right angles to the vessel. Yeah.
Thank you. And Dr. Pranjal wants to say something about. Yeah, we're not able to hear you.
Thank you, madam.
No,
Thank you.
you're not audible. You can remove your earphones. And no, you're not audible, Dr. Pranjal. I'm so sorry for that.
I'll go ahead and say this more thing, that is aortic clamps also should be readily available with the practicing obstetricians.
Yeah, thank you.
As
Dr.
Dr. Piley
Pranjal,
said, that
we'll
it
have
is
your
easier to
comments
apply
afterwards.
clamps.
Thank you, ma'am. And we can move on to the next session. Dr. Parikshit would like to, he's having some other engagement. So I think we would be going with his expert comments before the panel, if it is agreeable to all the panelists and the moderator. So
no, I think Dr. Parikshit has another talk at the same time. So I think we have to continue with the panel and then proceed for Dr. Tan's session.
Is that it, Dr. Parikshit?
Hi, hello. Good evening. Sorry, I didn't anticipate that our program will go beyond 5 o'clock. I'm so sorry. I'll come back once the panel is over.
Okay, then that's fine. That's fine. Okay, Dr. Rashmi, we go ahead then.
Yeah. So now moving ahead to our panel, in very interesting panel discussion. Dr. Nisha, would you like to put yes? The panel discussion on difficult situations during LSCS, time-tested solutions by experts. And the moderators are Dr. Surekha Taide and Dr. Sharmila Avyayu. Over to Dr. Surekha Taide, madam.
Okay, thank you so much. Dr. Rashmi, I must say that I appreciate Dr. Rashmi and Dr. Shalakha for taking this session so well. And of course, all the efforts both of you have taken and the whole team of ISOPARB executives who have been here throughout to make this a great success. So we go ahead with the panel. And I would like to, first of all, introduce the panelists, the moderator, Dr. Sharmila Avyayu. Everybody knows her as a great academician, and we have heard so many of her sessions, and especially I think she's a panel expert, moderator beyond any other compare. I have always attended her panels and found them so interesting, so knowledgeable. So she was the chairperson of the Clinical Research Committee in 1618, ICOG Governing Council member, National Coordinator for UNICEF, POXI, PCA, and MEDHA program. And wonderful person, I think, with great knowledge as far as, I must say, the research acumen of Dr. Sharmila. And of course, she is now probably going to be elected unopposed from the as VP of South Zone. So, Dr. Sharmila, welcome here. And other panelists here, we have distinguished panel, I must say, with persons like Dr. Ashish Mukhopadhyay, who's my dear friend, principal and professor and unit chief at CSS College of Obstetrics and Gynecology, great academician as such, and of course, a person who has such a practical knowledge, in-depth knowledge. Mostly he is interested in high-risk obstetrics, and he's also heading as a dean, a medical college which deals with specially obstetrics. Vice President Foxy in 1617, again GCC member, past president of the Bengal OBGY Society, and ex-chairperson of the Medical Education Committee. Very much privileged, Dr. Ashish, that you are there amongst us today. Our next chairperson is Dr. Shobha Gudi. We have already heard her in so many forums, and she is the chairperson presently of the Family Welfare Committee, professor and head of St. Philomena's Hospital, Bangalore, postgraduate teacher, examiner. Apart from that, I think she has so many affiliations, plus she has held so many posts, but I think she's a great teacher. I have seen her passion and how she is spearheading so many programs under family welfare. Madam, you are an inspiration for all of us. Your footsteps we want to follow. Thank you so much for being there amongst us.
Thank you.
And our next chairperson, next panelist is my dear friend, Dr. Mitra Saxena. Everybody knows her as a passionate person who is heading and chairperson of the Practical Obstetrics Committee. I think apart from what is written on the slide, I think we all know her for her way she, takes any task with so much of passion. We heard her just 2 weeks back. There was a webinar on, again, there was so much she wanted to teach as far as skills. Then she'll be coming with drills and thrills in the coming weeks. So welcome, ma'am, for the panel. And then again, we have other chairperson, panelists. Dr. Supriya Jaiswal, Secretary of the Patna Obstetrics and Gynecology Society. And apart from what is written on the slide, I must say that Dr. Supriya is a great organizer. As a secretary of the Patna OBGY Society, I have seen and attended so many of her programs. She has invited all stalwarts probably in Patna OBGY Society for talks. So we acknowledge her as a great organizer, and we are glad that you are part of our panel. Welcome, Dr. Supriya. And we do have Dr. Jyoti Banglowala, again, secretary of the thriving, vibrant society of Indore. And we are all waiting to be with you at Indore at the AICOG, and she's been part of the team who will be organizing the AICOG. We can see that she has worked on various bodies, and she has been member of IAEC and the Breast Committee of FOXY, a number of awards. Dr. Jyoti, I have known you as a great academician who have contributed to developing a lot of resource material for Practical Obstetric Committee. So welcome, Dr. Jyoti. And we have, again, next slide. I think we have Ashish. Dr. Ashish Kubre is my own batchmate from Government of Medical College, Nagpur. He's the director of the 7-star hospital, Nagpur. And here in Vidarbha, he's a force to reckon with because he's a vaginal laparoscopic surgeon. He's a robotic surgeon, gynec onco surgeon. And I think people from Nagpur would acknowledge the type of assistance he has given to all the gynecologists, obstetrician in Nagpur in case of massive hemorrhage. He's the person everybody will call, when there is any kind of bleeding or any, he's also the secretary of the Nagpur OBGYN Society. Thank you, Alka, for reminding me. When I try to, speak from my heart, I may forget to to include important things. So Dr. Ashish, very much pleased and honored to have you on board. So we would now start, yes, of course, Dr. Pranjal Sharma, who is our panelist, consultant OBGY from Amravati. Apart from that, Pranjal, I must say, is a great organizer. You know, so many things she has organized, organizing secretary of AMOGs, various zonal conferences, and whatnot. Everybody knows her here in Vidarbha as a person who can organize great events, mega events. So thank you, Dr. Pranjal, for joining as panelists. With that, I hand over to our moderator, Dr. Charmila.
Thank you, Sureka. Thank you so much for those kind words. I'm extremely honored to be in this program of Vidarbha chapter with great stalwarts like Dr. Ashish sir and Shobha ma'am and Mitra ma'am, and Pranjal along with Dr. Ashish Kubde, as well as
Supriya and Jyoti.
Yeah, 1 second. Actually, I forgot to mention Sureka's name here. She's a co-moderator along with me. We would request her opinions as we go. The esteemed panelists, Dr. Ashish sir, Dr. Mitra Saxena ma'am, Dr. Shobha Gudi, Dr. Ashish Kubde, Dr. Pranjal, Dr. Supriya, and my friend, Dr. Jyoti. Welcome you to the panel. Actually, it should be like a debate because we do not have extensive presentations or something, guidelines, nothing like that. You know that the opponent is wrong sometimes, but you tend to agree even if they are wrong. But we do not want that here. If there is something wrong, because nothing is right or wrong in medicine, science, it can be like each one's opinion is different. And what you've done over the years will stand us in stead whenever, like when we have a problem. So I request all the panelists to disagree when there's a question regarding any answer which comes, and we'll have to come to a consensus at the end of it. And one of the great dynamic persons, Dr. Ashish Mukhopadhyay sir, may I ask you, what is the preferred abdominal incision and entry for a cesarean section? Would you prefer Joel Cohen, fan and steel, Miss Laddock, or any improvisation do you have? Dr. Ashish sir.
Thank you, Charmila. Yes. So two charming ladies at the helm of affairs. One, Charmila Ayafu, another, Surekha Tayade. So two charming moderators and a galaxy of panelists. That's what we have. And we deal with the question like abdominal incision. Well, for cesarean section, I believe that I prefer Joel Cohen technique, always. There was a time when I used to be more cosmetically oriented and would like to go for that fan and steel technique just above the hairline, thinking that, well, what the girl in question or the lady in question will think about the future scar. Later, I realized that this is actually not the point. She doesn't mind as long as she becomes healthy and back to the action quickly. And apart from that, the cosmetic beauty, there are many, many more advantages with the Joel Cohen technique. And to make it more understandable, I have taken my son's guitar for a demonstration of the incision, on the abdomen. I hope it is visible.
It's visible, yes.
Yes. Suppose this is the symphysis pubis. Can you see the symphysis pubis?
Sureka, can I suggest that you put a spotlight and stop screen there for a minute?
Yeah. I'll take just 1 minute because I thought this is important to explain to everyone. So this is the symphysis pubis, and this is the area where we go for the phalansteal incision, just above the symphysis pubis. We call a hairline incision. Okay. Now this is these strings of the guitar are like a, rectus abdominis muscle, and we all know that this part, the infra-umbilical part, is the bigger section of the rectus abdominis muscle, and there is no posterior rectus sheath. So with that, if you move your incision a bit higher, then what happens? You can move the rectus abdominis muscle like the strings of a guitar. You cannot do it here, just above the symphysis pubis, meaning thereby you have to dissect a lot of muscle on the upper flap. So in Joel Cohen, I prefer to do it this way because I never, dissect the rectus sheath anteriorly to a significant extent, just stretch it with my hands. And most of the Joel Cohen approach is based on this, that you stretch the muscle because your purpose is to take out the baby. After that, it becomes quite manageable. And then you stretch the muscle like this side and this side. No blood vessels are cut, minimum blood loss. When you stretch it, I think this is a great advantage. Joel Cohen entry, abdominal incision is a great advantage. And you have to just try both the things and then realize how difficult, how easy it is. Joel Cohen, which is approximately 3 centimeters above the, phalansteal level, and the 2 points are fixed a bit longer and a more straighter.
What about Misgav Ladakh? What do you think about that?
Misgav Ladakh is, you see, the Misgav Ladakh is not the incision. Misgav Ladakh is the approach inside the abdomen. Like I said, the stretching of the rectus abdominis muscle, you cut the rectus sheath in the middle, just put a nick and then stretch it, or rather put a blunt scissor and extend it. You do not have to hold it with and dissect the fat and subcutaneous tissue and all these things. You just have to stretch the rectus sheath.
No, I'm asking like practically, what do you think about Misgav Ladakh? Because Joel Cohen and Misgav Ladakh is almost similar, except for the incision also, it's like 5 centimeters above from Misgav, so that corresponds to Joel Cohen also.
Yeah,
so
they go hand in hand. They go hand in hand, and the advantages are many. As I said, one is the entry is easier, avascular, relatively avascular, and when you take out the baby, the uterus becomes smaller, and the muscles come back in the midline, which prevents future recurrence of the divarication of the recti, which is so important below the umbilicus. And there are minimum blood losses. There are many advantages. And also, I have followed that the patient's postoperative pain is much less because you're doing much less dissection of the rectus sheath. So I'll rather prefer Joel Cohen.
Thank you so much, sir. Thank you. Mitra ma'am, what will be your entry for a morbidly obese patient? Will you change yourself? Sir has said that Joel Cohen is much better. Mitra ma'am?
In a patient who's morbidly obese, personally, I'm still going with the transverse incision because I find that very, very comfortable. However, I mean, for a morbidly obese patient, we have to be careful about the very, very thick layer of fat. An extra assistant, I would go for that. And when it comes to opening the abdomen, I'm very comfortable with the modified funnel seal, slightly higher than the usual level, and a big transverse funnel seal incision only, with additional precaution of an extra assistant. And
will you go for any indication of vertical incision in a morbidly obese patient, like a 110 kg?
No. I mean, like I only go by transverse. I would go for vertical depending upon the some other indication associated with obese patient. What I would be very careful would be that I know the weight of the baby, I know the presentation, I would be prepared for everything with that. As far as opening the abdomen, I've stopped using vertical incisions simply because I go with transverse, especially also in vertical incisions. Later we have more problem. Healing and all is much better. So
access does not seem to be a problem with transverse incision. So
no, I don't think. I mean, I am personally not.
The guidelines also say that you can go for a transverse incision for a person who is morbidly obese, because even though there's a theoretical risk of increased surgical site infection, it's not been proved. Surekha, can you mute that person who's making some noise there?
Yeah, the host, please.
So, as Mitra ma'am said, even though it seems theoretically better to have a vertical incision, it's not so. It's always better you go for a low transverse incision. Any of your modifications, as Ashish says, Joel Cohen can be modified. Yes, ma'am.
In fact, there is a crease. I avoid that crease because when the fat will come over because of moistness, there is problem in healing. So I avoid that crease actually. And also after the surgery, I make sure that the fat stays up. So I make sure that
Just a minute. I think the phone which is labeled supports iPhone. I think that phone has to be muted.
Yes.
Yeah. Please go ahead.
So, I mean, like, I find that transverse incisions are they do very well. Yeah. Only thing is during assistance, an extra hand, and then putting the sheet up and having a person to retract that helps me a lot. Yeah, upper panniculus. And also after closure, I make sure that with the chunni or something, we tie the abdomen a little bit up, just keep it up so that the healing. of the wound is good. And I tell the patients that they have to avoid too much of sweating and all that. That's it. Otherwise, it heals very well.
Yeah, thank you, ma'am. So, Shobha, ma'am, would you like to create a bladder flap in a cesarean section? You're doing for year ages together.
Yeah. Yeah, I think it makes sense. There's a lot of noise.
Yeah, the sports iPhone.
Yeah.
Who does it belong
There's
to?
a lot of noise.
Please mute it.
Yeah, I think it is important to identify the peritoneum and be very sure about where the bladder is. Creating a bladder flap is not actually necessary in all cases, but it is necessary in women who have had a previous cesarean scar. That is something where we cannot miss at least a 5 centimeter sharp dissection of the peritoneum away from the lower uterine segment, because sometimes the bladder is higher than we can, think. It is
So
higher.
if you identify correctly, there's no need
There is no need. There is, provided the lower uterine segment is well formed. It's important to identify a proper place for the incision, which is
ma'am, one second. Surekha, we can add them in the panel also that support iPhone if they want.
Yeah.
They seem to have some information they want to see.
Good idea.
Yeah. But
Shobha ma'am, please continue, Shobha ma'am.
I think that is Jyoti Banglowala.
Okay.
She hasn't labeled herself, but presently we'll mute her, and when it's her turn, we'll unmute.
Okay. Shobha ma'am, please
Yeah,
continue.
so it is, if the anatomy is very clear and the bladder is much down, I don't think that there's, because sometimes vessels open up and we spend time in hemostasis.
Yes.
It's not routinely recommended in all, as long as the anatomy is very clear. But in women with previous cesarean, with adhesions due to any reason, it is very important. So a mobile peritoneum, a very, very lax mobile peritoneum, and the bladder contour seen very well, there is no need to create. And if the lower segment is well formed.
Well formed, yes.
Remember, the lower segment should be well formed. But if the lower segment is poorly formed, then once the baby is, removed, we are not sure. The bladder looks very, very close then. So during suturing also it becomes tough. Therefore, if the lower segment is not well formed, it's better to dissect it down.
It's actually more for an like an impacted head. So when you have a long elongated bladder sitting on the lower segment, there it's better if you see where you're putting your incision. So be very clear. Sometimes you may need to form a bladder flap only in that instance, so that you do
and
not.
Also in adherent tissue where the peritoneum is adherent. Sometimes peritoneum and bladder both are adherent. Sometimes the peritoneum is free, but the bladder is adherent. Therefore, in women with previous scars, it's important to raise the bladder flap. I think that, and it's important to use sharp dissection to create.
Always, yes. Yeah. So in a systematic review in 2013, they have said you discourage the routine creation of a bladder flap. That's very clear. But suppose there's been a failure of descent of the low-lying part, and the bladder has become adherent, as ma'am said, in a previous cesarean. Theoretically, sometimes it's higher in the lower segment in these instances. It's worthwhile creating the bladder flap before you go ahead with a hysterotomy for a cesarean. So, Ashish Kubde, sir, what is the preferable hysterotomy incision on the uterus? When will you go for vertical? Ashish Kubde, sir?
As such, even if you have to perform the hysterotomy, even if you think of hysterotomy ab initio, but there is no need to change the plan as far as this incision is concerned. You can very well perform this from the transverse incision. Whatever, whether it is the phalansteal or whether it is the Joel Cohen's incision, you can easily do.
And actually, Dr. Paley sir also was saying for a placenta accrete subspectrum, it's better if you go for a vertical incision. That's like a classical. That is one instance where you would rather go for a vertical incision.
But
sometimes
if you ask your assistant just to raise this upper flap of abdomen, and if you use this reverse type of retractor, easily you can give the classical incision and you can deliver the baby. And once the baby is delivered,
actually,
then
sir, actually, I'm talking about the vertical incision of the uterus.
yes, yes.
So
only thing you have to ask your assistant to raise this abdominal, this cranial part of this incision. Just paint it, give the classical incision, deliver the baby, and after delivering the baby, uterus becomes small.
Yes. So you can actually put a vertical for a preterm delivery patient when there's no lower uterine segment being formed, or in a transverse lie with a back down. There, it's worthwhile going for a vertical incision. There also, avoid putting it in the contractile part of the uterus, that is the upper segment. Try to go for a low vertical, where in the lower segment. Yes, Ashish sir, you wanted to say something?
Yes, I just wanted to react to what Dr. Ashish Kubde was saying.
Yes,
He's meaning that the low transverse incision on the abdomen should not be a problem even for a
classical cesarean.
Classical cesarean.
I beg to differ here, because yes, approaching the upper part of the uterus may not be a problem, but there will definitely be problem in delivering the baby, and also then after manipulating the uterus. So I think I will always go for a vertical skin incision in cases of wherever I want to go for classical section. Now, I understand the point that when there is undiagnosed placenta preta or undiagnosed adherent placenta, then you have already approached with the section, I mean, transverse incision, and then go for the classical. That's a hell of a job. But that though there are extremely rare situations, instead of trying a T, I think it is always better to way that Dr. Kubde has said. But otherwise, if it's a planned section, then I'll go for a
vertical.
Sometimes if we have an anterior placenta previa with the transverse lie preterm, everything is against. So lower segment is not well formed, presentation is not favorable, and also it's preterm. So, and there is big vessels running on the anterior lower segment anterior wall. So there I found that anterior low vertical incision is very helpful, because we can always extend it up and remove the baby and avoid the major vessels. These are the times I've given, and then I always mention in my notes that I've done a low vertical cesarean section, vertical.
Yes. Ashish Kubde sir, like when will you extend your incision when you've already taken a transverse incision in the lower segment? Where are the instances you would like to extend the incision?
Yes, when the head is deeply engaged, then it's very difficult. Whatever the maneuver you choose, whether the pushing the head from the vaginal side or delivering the baby by breech, then in such cases, you may need to extend the incision, either because laterally there is the space crunch, therefore you have to go for the J-shaped, somewhat extended J-shaped incision. And that is the main concern when there is the head is deeply engaged.
Actually, on the like the opposite side, it usually happens in a mobile head, where you will find it difficult to pull down the baby, and sometimes a J-shaped or a inverted T may be necessary. What do the other panelists say?
I will never go for an inverted T, but I rather compromise with the J-shaped incision.
I have found U-shaped incisions very helpful, and I feel that whenever there are malpresentations, especially transverse lie or even breech, not a well-engaged breech, but a foot link, something like that. So there I find that giving a U-shaped incision, it always helps, because it doesn't go into the sideline and it gives more room.
Madam, what do you do for a mobile head? What do you do for mobile head? What do you do for a mobile head, Mitra ma'am?
Mobile head, my first choice is vacuum.
Okay, only one vacuum. And Shobha ma'am, what is your choice for mobile?
My choice is actually forceps.
Forceps. Ashish sir, Mukhapadhyay sir.
No, I will allow the liquid to drain out, let the head descend, and only when it's necessary, I will go for a forceps, not vacuum.
Forceps.
Same
Supriya.
Forceps, ma'am, always.
Ashish
I use forceps.
Kubde sir, what is your choice when there's a mobile head?
Mobile head, my choice is the Ventus or the forceps application.
So you
another very easy way is to just convert it and deliver it by breech.
Okay, reverse breech for you. Pranjal, what is your choice? Pranjal, what's your choice? Pranjal, we are not able to hear you. Yeah, now, yes. Not audible. Okay, we'll get your opinion at the end. By the time, clear your audio. Surekha, what do you think is right for a mobile head? There's a group which says forceps, 2, 3 of a vacuum. So it's 3 and 3. You have to give us the consensus.
I think it's the skill, the training which you have achieved in there. That is important.
Yeah,
don't try something which you are not skilled at.
Yeah,
So,
listening to a webinar,
we have been trained to allow the liquor to drain. Let the hair descend. No need to panic. There is enough time. You can deliver, I think, easily. So if you are skilled with vacuum, that's very good. If not, then you just allow the head to descend and then you take out.
Munroker says that in a free head, may I mention one thing, that in Munroker it is very clearly mentioned, if it's a lots of liquor and be free head, you can place your incision a little bit higher. So you palpate the head and you place your incision a little bit higher, the head will never go up. There are so many strategies, but I find vacuum very safe.
But if sometimes what happens, the head slips, then the reverse breech is very comfortable.
Always taking the breech is much comfortable in a cesarean section. Yeah. Pranjal, what about hysterectomy incision? Would you like to go for blunt or a sharp dissection? Pranjal?
Pranjal,
I don't know, something is wrong with her audio. Can you join with the mobile, Pranjal?
Yeah, I can. Can I react to Dr.
Now you can hear
opinion?
1 second. Yes, sir. Yes, sir. Yes, sir.
For a floating head, I mean, I do not prefer a higher incision on the uterus. I keep it reserved for the deeply engaged head, deeply impacted head.
Yes.
The reason being that if you keep it for the floating head also, the later on the delivery of the head may become difficult, and after that the suturing also becomes difficult. But in a deeply impacted head, I think it is extremely useful to take out by reverse breech. That is why I always keep a normal incision for the floating head.
Okay. Pranjal, what about the hysterectomy incision, blunt or sharp?
Now you can hear me?
Yeah, we can hear you.
Yes,
we can hear you. Yes.
The blunt extensions are supposed to be like they are superior to the sharp one. Many studies that back up the blunt.
What do you do? What do you do?
I usually do the blunt.
When do you go for sharp then? When do you go for sharp?
Just in some cases I go for sharp. If I see some big vessels or sinuses at the corner where I want to avoid the unintentional extension. Some cases I go for the sharp cuts, or if I see the velvety surfaces suggestive of some endometriosis at some corner, then when I need a precise cut, at that time only I go for the sharp, but otherwise blunt. In blunt also, I prefer the cephalocaudal extension and not the transverse extension. Cephalocaudal extensions are supposed to be like they bleed less and while extracting out the baby. So definitely the not sharp.
Okay. What is your opinion about that mobile head we were talking about? We didn't get your opinion.
Madam, definitely ventus I prefer first.
Okay.
Because
so 3 to 4.
What, madam?
3 to 4 ratio. 3 people want.
3 to 4. Yes, usually like 70% I go for the ventus.
Okay.
And 20% maybe forceps and then reverse breech extraction.
Okay, perfect. So as you said, the blunt extensions are much safer, but sometimes you may need to go for sharp, like as you said, in a bleeding vessel if you see at the corner. And as all the studies have said, a cephalad-caudal direction of extension of the uterine incision is much safer than going laterally and injuring the uterine vessels. That's much safer. Supriya, do you use any? See, all of them have talked about vacuum and forceps. What about tocolysis to facilitate birth? Suppose she's contracting, and what are you going to do? Do you use tocolysis?
Yes. No, actually, I don't have much experience with this tocolysis during the cesarean. So usually I use the like Ashish sir said, let the water drain and it really comes down. I apply the forceps. I apply my hand, the curvature of my palm, and I try to catch on the baby and lock the forceps and take out. Routinely, I have not experienced much of this type of
tocolysis. See, many of us do not talk about that fundal pressure.
Yeah.
But cross your heart and tell me how many times you have applied fundal pressure for delivering the baby.
A lot of time, madam. Shamila ma'am.
Yes, we have. We don't want, but then we have done that.
We have done. Okay. Yeah. Anybody else has used tocolysis to facilitate the birth of the baby? Any panelists has used?
Yeah, see, Charmila, there are instances when there will be ring formation due to obstructed labor, or in prolonged dry labor, there will be a lot of, tonicity in the uterus, and it resists the stretching what we apply. And, sometimes there is absolutely no space, especially when we are doing a cesarean in a case where hypertonicity has happened, and tachysystole, overstimulation, hyperstimulation.
But,
In them, we may need to use.
What
And
tocolytic you use, ma'am? What do you
yeah,
use? What is the drug you use?
see, the terbutaline subcutaneous injection
It's not
really
available
works
for
enough.
us. It's not
It is there.
available.
It is there for us.
Bangalore is there?
Yes,
I don't
yes.
know.
250
That would-
microgram subcutaneous works well for acute tocolysis in active labor.
Okay, ma'am. Thank you.
Yeah. So it
But
does,
it is not
and it
available.
is very easily reversible.
Only in metros it's
without
available,
dosage.
Mitra, ma'am. It's not available in small places. Bigger places, they've got terbutaline still, actually. So to assist delivery. Yes, ma'am.
Giving some little bit of sedation or this nitrous oxide, something like that, inhalational anesthesia, just to put your hand inside.
Relaxation, just for that relaxation.
Okay, we come to the last part. Dr. Jyoti Banglawala, deeply impacted head. Already opinions have been given. What is the one you prefer?
We need to unmute Dr. Jyoti. Okay, supports iPhone. Is she there?
What is this?
So somebody is playing your guitar, sir, I think.
Now the incision is over. I have entered into the comment.
Jyoti, are you there? Jyoti? Okay, can I request the other people to take up to find out like what's the opinion on their, what is the technique you use for a deeply impacted head?
I think this has been discussed quite a lot in this beautiful seminar, and I believe
Supriya, mute yourself. I'll call you.
And I think the in last 5 years or so, 4.5 years, we are using the reverse bridge technique. Previously, we used to do a lot of pushing, and we used to keep a separate assistant from the vaginal end. And then we realized that it's actually not helping. The hands are meeting, but the baby is not coming out, and it's not getting up. So we tried the other way. That means the Patavardhan method. And training in Patavardhan method took some trouble, and there were some difficulties associated with that also. So now we are trying this reverse bridge delivery method, and is giving extremely useful this thing incentive to us, and we are very happy. And even our junior can be easily trained on the reverse bridge technique. So I believe I am definitely gone for this reverse bridge. And
in case of if there is a liker totally drained out. Sometimes there is.
Actually, we also anticipated that. We thought that, but it doesn't really.
Yes, but
doesn't really cause much problem. Yes, of course. And in an absolutely dry labor, one may want that, but it doesn't happen normally. In many cases, we are having prolonged rupture of membrane. Obviously, with the deeply impacted.
Those cases, yes. There we need Patwardhan maneuver. So while giving the incision, we have to be very careful that our incision should precisely come over the end, the shoulder of the baby at that level.
Yeah. So one person is for reverse breach. So one person is for reverse breach. One is for Patwardhan whenever necessary. Mitra ma'am, what do you say?
What I'm saying is that in deeply impacted head, when I choose either, but I have to make up my mind what I want to do. I many times disimpact my own self and derotate it and push it above the brain, and it goes fine. And after I'm done that, I ask another scrubbed assistant to put her hand in the vagina and keep it there. I've never faced any problem if I have myself derotated the head and pushed it up. Otherwise, if I'm not able to, if I haven't done it myself and I'm in a hurry, and if I have have planned for a Patwardhan or a reverse breach, I always place my skin incision higher, uterine incision higher, so that then I'm not going to think about getting it disimpacted by somebody else. Either I do it myself, disimpact it, and then take it out as cephalic only, or if I'm for Patwardhan, then I don't let anybody handle anything from below. All I do is my skin incision is also higher a little bit, and also the uterine incision. Then Patwardhan is very smooth. Back is anterior, it is Patwardhan. Back is posterior, then take out whatever is coming. So the first arm, then the same side foot and the other foot, and it comes out very easily. So that's the
Dr. Ashish Kubde, sir. Shobha ma'am, yes, yeah. Shobha ma'am. Shobha ma'am.
No, let Ashish say, then I.
Yeah, Ashish Kubde, sir, what is your preference?
Yeah, first I prefer the head push from the vaginal side, and at that time I give push at 2 levels. The assistant is giving the push at the level of the head, and as our incision is usually at the level of the shoulder, the surgeon gives push at the level of the shoulder. Means at 2 different levels, shoulder level and the head level. Therefore, many times it gets de-impacted. And if this is not successful, then the another way is the reverse breach. As far as the Patwardhan is concerned, if back is anteriorly, then Patwardhan may be possible. If back is posterior, then it is very, very difficult to do the Patwardhan method.
If back is posterior, we can't do Patwardhan. If back is posterior, we
Reverse
really can't.
Patwardhan is possible.
Yeah, reverse Patwardhan means the reverse breach. Just take out
it should be reverse breach extraction.
It's the same. It's the same. Reverse breach. Acha. If the back is anterior, how will you put your hands above and bring the foot? You know. So if the back is anterior, it's easier to do Patwardhan, one shoulder, then the other one, and then you put your both the hands around the trunk, and then one person pushes from above, fundal pressure, and the whole body comes out very easily. In fact, in last year only, I have learned Patwardhan because I was from the older group of disimpacting the head myself and getting it out without any extension.
Shobha ma'am, what do you say?
Yes, see, I have a couple of things to say. This is one field where
I think Dr. Jyoti has come. Yeah, after
Vila.
Shobha ma'am. Yeah, Shobha ma'am, please continue.
So we must actually think about how we are going to train our postgraduates in this particular area. It's important. Now,
So,
when I see
do reverse breach.
when I see the literature and when I see people talking about it, I feel that Patwardhan requires slight training. It is not, as easy as breech extraction. I must say that breech extraction is possible both when back is anterior and when back is posterior. Because when the back is anterior, also when we get hold of the anterior foot and bring, the back normally comes very, very nicely, and then it follows the other limb also follows, and the shoulders also follow. So it is possible both when back is anterior and posterior. I have done it. But Patwardhan requires slight training because one should have the courage to deliver both the shoulders completely out and then gently apply pressure on the spine to bring it down. Well, both these techniques require some amount of space in the uterus. Most often when there is advanced labor, the LICA would have drained out and the space is a constraint. So usually what is our training for postgraduate is first is disimpaction. And we have a particular technique for this. We use a lot of antisepsis in the vagina beforehand. Very nicely we paint it with betadine, and we keep the assistant with the hand in the vagina while we are painting and draping. And with a very lubricated hand, the whole hand should be in the vagina. It should not be only 2 fingers, because if we apply too much of finger pressure on the head, there is damage to the head. It is because of reports of intracranial and scalp injuries that this method came into disrepute. So one should remember to use the cup of the hand, which gives 5 points of pressure. And very gently, it is important to know a little bit how the head is, whether, the occiput is there, keep it flexed. and towards the incision. Keep it flexed and gently towards the incision. So sometimes when they are untrained, they just push it in a cephalad direction, and it doesn't serve because it goes into the posterior part of vagina, or into the posterior part of the uterus. It is not, we are unable to get it. The shoulders still come in the way. So it's important to push it towards the, and as very rightly said by Ashish, we also put gentle pressure. The word is gentle because it shouldn't result in uterine damage. Gently we push the shoulder up, and these difficulties very often come when the baby is large in size. So that is why the space constraint happens and we are unable to do the reverse breech. So disimpaction is a good method, provided we use gentle, we use cup of the hand, we use gentle pressure towards the incision, and not somewhere posterior. And most often
in Bangalore, you have that fetal pillow?
We don't have. It may not be cost effective, I feel, because once I found out it looked expensive and it looked disposable, right? Isn't it disposable?
It's disposable.
So anything
Dr.
disposable
Shobha,
doesn't work for us. Yeah, thank you.
Dr. Shobha, I would like to tell you that those of the younger generation, Dr. Surekha and so many of my colleagues up north, they are so conversant with Patwardhan and just on their direction. I mean, I am an age-old disimpaction, pushing the head up, wala, perfected person. And I just on their verbal, guidance, I was able to do Patwardhan very, very easily. And suddenly you realize that when we trained, we were told, shoulder aa raha hai, isko upar rakho, isko andar bahar batane do. And the concept of Patwardhan is very simple. Jo aa raha hai, usko aane do. And it really comes out very easily. So I think that, yeah.
May I request Jyoti to say a few words before we go on to the next question? Jyoti?
Yeah, Dr. Jyoti is having some problem.
Okay.
Jyoti, please open up your...
And as far as...
Can we unmute her, please, the host? She's trying to unmute and she's getting,
Yeah. Mitra ma'am, you continue.
Just trying.
Disimpaction mein, my take is that I am the operator. I am the one who knows how to untwist. We know when the head is descended and coming down, there is internal rotation. So if we derotate the head first, gently, as Dr. Shobha said, lubricate it with our full hand and push it up. And it's so easy to push it above the brim. And once it's there, the assistant only has to keep her whole hand inside. She doesn't have to do heroics. Already I have pushed it up well above and I'm quite comfortable. So once that is done, koi problem hi nahi aati hai. But for those who don't know how to disimpact, and go ahead with Patwardhan. All the new girls here in Rewari are conversant with Patwardhan very, very easily, and they don't have extensions at all. So it's really very easy, not so difficult.
Jyoti has joined?
She's having some. Go ahead with the next question. So I'd just like to add again here that Sharmila, myself, of course, and my students, all postgraduates are very, very conversant with the Patwardhan's technique. So we are not at all having any problem. Even if there is no supervision, they are able to take out the baby, and that's Patwardhan. We usually not following the push technique.
I have been taught in Grand Medical College, Mumbai, where this technique was brought into the history. Actually, it was done in Grand Medical College, and as Shobha ma'am said, it's not, as you said, it's not difficult at all, ma'am. It's one of the easiest technique to do. You do once or twice under the supervision of a chief or an assistant, you are done. It's not, I can take out even anterior and posterior without any problems with Patwardhan. I've never gone for disimpaction. I've never gone for even reverse breech. Only now, this last 1 year, after listening to so many people, I'm trying out reverse breech, which is also equally easier. But
that's what I wanted to ask Surekha. Have you tried teaching your residents?
Yeah, reverse breech. We do reverse breech, and see, if the incision is little higher, then reverse breech is quite, I think, comfortable. My professors are very, very comfortable with reverse breech. I mean, we have Dr. Samal here who always does reverse breech, and she doesn't want to do Patwardhans at all. So actually, both the things, I think, have their own advantages.
We have tried so many years, but I can say with certainty that after trying, say, Patwardhan for last, say, 7-8 years, now we have resorted to this reverse bridge, and we are extremely happy, both providing training as well as doing it ourselves by the juniors.
Yes, I agree to that. I think we have been doing Patwardhan so much that we are not training for breach. I think we should be doing more trainings with breach. I agree totally with that.
In fact, I just want to share that my mother, who I also learned from her, in free heads, she always did this reverse breach. And it was so easy, so gentle that, just hold one foot and it bring the whole baby out. So I think it's just being gentle, whichever way you're taking it out.
Suppose the hand comes out when you're trying a reverse breach. What will you do? That happens. Because when you're trying out in a deeply impacted head, you're trying for the leg and you'll have the hand there. What are you going to do?
Charmila. It can
just ignore the hand.
Yeah.
Just
put the hand inside and take out by the breach.
You can just continue.
It never goes inside. It never goes inside.
It never goes.
Also happens.
Yeah.
So we should not.
Never goes.
Are you talking about the deeply impacted where the hand comes out? Then do the Patwardhans.
No. So,
during C-section, you ignore all hands except the surgeon and the assistant.
Then go for the breach. That's what I mean. That point you have to remember. Always go for the breach. Ignore the hand. Don't try to put the hand inside again. It doesn't. In Patwardhan, it will be difficult with the dry labor when the hand has come out. You cannot rotate it and bring. Then that reverse breach will help. Ignore that hand. Put your hand inside. Go for the breach and bring out the breach. That will be much easier at that point of time. So as we have discussed so much on this, but all the studies have said that reverse breach is much better than a head push or a disimpaction. But whatever works for you, do not change what we have done for years together. But Ashish sir has put up a very important point. Learn to do reverse breach, as they have done many cases, and it seems to be much easier to learn compared to the other techniques. But as a proponent of Patwardhan technique, I would say it's not so difficult. You can always learn. It's a easier technique only. So there is one patient I would like the opinion of all the panelists. She's a 30-year-old primary, has had one laparotomy in adolescence, no details available. Then she had some burns and she had a skin grafting done for this burn contraction in the abdominal wall. She's full term now. And if she goes for a cesarean, what are you going to do? What is your plan of entry? Ashish Mukhopadhyay, sir.
Yes, I just want to know what is the extent of the incision, this thing, skin grafting,
So the picture, I put up the picture there.
Well, I can see the suture, but I cannot see the extent of the grafting.
The umbilicus is actually very low near the symphysis pubis there. The umbilicus.
Okay, umbilicus is low. Okay.
Yes, fine. It's near the pubic symphysis actually. It's contracted so much.
Okay, can we avoid this scar and go the incision below this line? Is it possible? If there is no,
so you would like to go below that. You would like to go below that. Okay, Mitra ma'am.
Yes, you have to go above this. You see, this second picture shows that the symphysis pubis is, quite incision is quite low and almost vulva is showing. So I'd rather go for above this thing, but I will avoid this area.
So the umbilicus will be below your incision.
Yeah, that's the problem.
Okay, Mitra ma'am.
I would first actually try and find out the history ki laparotomy, why was the laparotomy done?
No detail available. No detail at all.
No detail. Is this incision is of the laparotomy, right? The one going above the umbilicus. Okay. And I would feel the abdominal wall. Is it stuck to the uterus or can I have any mobility of the abdominal wall? I like to palpate the abdominal wall.
You cannot move it. It's stiff. It's stiff. Thick and stiff.
I think it is safest to go vertically so that, because we really don't know how we will access the lower segment. Actually, skin grafting is very superficial. So we are not expecting any adhesions because of the skin grafting. But I am worried about the laparotomy. Though I would be more worried about intestines under the incision. So it's not an easy thing.
So vertical for you. Shobha ma'am. One horizontal, one vertical. Yes.
No, I think I will do
lateral.
Jyoti is saying something. Yeah, Jyoti wants. She's come rarely inside. Yeah, yes.
It should actually here is the Prime Minister program and badly network issues there.
No,
all
we don't want
network is
Modi
gone.
to say anything. We want your
Yes.
opinion. Huh?
Yes, it should be vertical, but little bit laterally left
Okay.
side.
Okay. So she's vertical and lateral. Lateral to the right side or to the left side?
Left.
Left. Okay. Shobha ma'am.
I think I will ask a sonologist to map the, underneath the skin where any adhesions are there.
No opinion available.
No,
they said correlate clinically. Correlate.
Yes, I would try to plan the incision as close to the internal incision of the uterus. And as Dr. Ashish said,
You're going for transverse.
Actually, transverse below the previous scar.
Okay,
Yeah,
so two transverse.
Or I would excise the previous scar and go through it. Yeah.
Okay.
Either of
So that is above umbilicus or below umbilicus?
Below umbilicus.
So you're below umbilicus. Pranjal, yes.
But see, the contractures were there. So the skin grafting, whatever this degree 2, degree 3 burns may be there. So the whatever the things are there, it is in the skin only. Another problem is that she had one laparotomy. So one for sure that we are not going to get our incision transumbilically or above the umbilicus, because in that case we will be going towards the ligamentum teres, which is connecting to the liver, and we will be in the mess.
So what do you want?
So one thing is that we will go below, like our routine incision, just above the symphysis pubis transverse incision. Number one. Another laparotomy scar, along with the laparotomy scar, we can go. That is the second option. One thing for sure.
Only one you can do. You cannot do two on this patient.
I will go with the simple one. I will go the simple one.
What is a simple one? Transverse.
This is the phalanxitial incision, but the one thing is for sure that we are not going to use any electrocautery incision in this case till we open the peritoneum.
Your incision is transverse, sharp dissection, no cautery. Okay. Supriya.
I'll avoid that area of the graft area. I'll try to pull up the abdomen and give the transverse incision below the umbilicus.
Below umbilicus. So Ashish Kubde sir, you will give us a final.
My incision is vertical right paramedial. It will be in the virgin area.
So all of you have done different areas. So it's transverse, above umbilicus, transverse, below umbilicus, right vertical, left vertical, and all that. So, but luckily for us, she delivered vaginally. She delivered normal.
That was nice.
Thank you so much.
One thing is
that is very trick question, Charmila. That was a trick question. I thought the patient was scheduled for cesarean, so you are asking.
She delivered normal. We had to keep ourselves ready, no madam, if something incision and all.
That was great. I knew the answer, but I kept quiet.
It was a rollback, right?
We had to.
Positioning of the umbilicus is very...
No, she's a primey. She's a primey.
Okay, that is something I missed. Okay.
Charmila, I think we are running late, so
I
have some questions to ask. So,
I'll just finish.
Allow me. Thank you for that wonderful.
One second. I'll just finish up. I'll just finish it up.
Please.
Joel Cohen better. Low transverse better, even in obese patient. Discourage bladder flap creation. Low vertical uterine incision in a preterm without a well-developed lower segment for a transverse lie with a back down presentation or a placenta accreta. Hysterotomy should be extended bluntly in the cephalad-caudate direction. No randomized trials to support or refute the use of tocolytic agents or any instruments to facilitate the birth of the baby at the time of a difficult cesarean. And for a deeply impacted head delivery, reverse breech technique is much better. Thank you so much.
Yeah, so we go on to the later part of is the screen visible?
Yes, it's there.
Yes.
Yeah. So we go ahead with continue with the, where is the slideshow? Here it is. So again, thank you, Charmila, for that wonderful debate and really wonderful interactions. So we go ahead with the case-based discussion here. 28-year-old, second gravida, previous C-section, severe preeclampsia. She has huge ascites. So key points are huge ascites, and she's been taken for cesarean section with an estimated fetal weight of 1.2 kg. Ashish sir, for you, what problems do you anticipate in this patient during LSCS? How do you manage?
During LSCS. Okay, thank you, Surekha, for adding an extra A in my name. But I just wanted to know a few things about this patient. whether the period of gestation is number one. Number two, whether the patient already presented in labor or not. Okay. Now, if I get to know these two, since the EFW is 1.2 kg, I presume that it is period of gestation something like 32 or something like that.
Yeah.
Okay. And
you're right.
I assume that cesarean section will be undertaken by spinal anesthesia, the anesthetist team. So I will request with a folding hand to this guy that please don't preload the circulation in this lady particularly. She's already having ascites. She's already having, what else does she have? Huge ascites and pleural effusion. So please don't preload the circulation. And in fact, be careful about every drop of fluid that you are administering in this patient. And then careful watch on the central venous pressure. If it is possible, I'll insist on the anesthetist. Now, after I have gone for the cesarean section entry, I may anticipate that the lower segment is not well formed. So naturally, there will be a chance of more bleeding, and also there is some chances of injury, etc. And so the direction of the pool will be cephalocaudal. That should do. And the bladder flap difficulties may also be anticipated. And about the placenta, the location of the placenta we need to know. If we know it from beforehand, it is better. It is anterior or lower segment or upper segment, etc. So I don't know anything about the many problems we can anticipate during the cesarean.
Yeah. Yeah, definitely. Because see, this is a small baby and the lower segment is not formed yet. Ascites is there. And we have so many times done this. Now, one thing I would like to stress is the positioning of the patient. Positioning. I think Jyoti have to mute her again. So standard practice is to position the operating table at the left lateral or put some wedge below the, that is important to give a clinch here, because the noise is coming from where? Okay, thank you. So the anesthesia, rightly, Dr. Ashish, you have to request for the, particularly for giving not too much amount of fluid. That's important. Then ascites, as I've said, you have to be careful to drain out the fluid. Don't be in a panic to deliver the baby very quickly. Allow the fluid to, drain off, suction it out. And then, of course, the lower segment is not very well formed. So you will have to give that sort of a kefala, the J shape. But instead of, stretching on it, you can use a scissor to extend the incision. Retraction may be difficult. So good assistant is required here. Take care that you may have two drains. Take care of the spillage. Sometimes, so much amount of ascites that everything, the spillage is there. Wait for the ascites to drain. Take care of the hypotension. And of course, closure also sometimes become difficult because of the thick, the incision is there and the layers are difficult too. So this patient actually, this is a 2 case. LUS was not formed, bladder was advanced, patient was very obese, retraction was difficult, 1 liter of ascites was drained, then baby was taken out, 1 CPAP was on, and then by oxygen by prongs, now doing well with oxygen support. Mother actually had bilateral papillary edema. She had to be given injection mannitol. Repeated fundus examinations were done for her, and now the patient is doing well. So thank you, Dr. Ashish. Wonderful practical tips for all the viewers. Dr. Shobha, ma'am, this is for you, second gravida. I'm just moving a little bit quickly because we have one more session and Dr. Parikshit is waiting for us. So she's a previous cesarean section, 38 weeks, reported with labor pains. You found that there was scar tenderness. She was taken for LSCS. Now you see such kind of ballooning. The cesarean section scar is very thin along its whole length. And anterior uterine wall is completely deficient, leaving a visible bulge. And you can also see the baby moving underneath. So now, Dr. Shobha, for you, where would you plan the uterine incision? What precautions do you want to take during the opening and closure of this patient?
Yeah, I think not much in our hands about the incision. The uterus is already open. So we need to incise this peritoneum on the upper part as high as possible. Preferable to find a plane between the membrane and the peritoneum if possible. Most often it's not possible. and reflect the peritoneum down, and then open the membrane and deliver the baby. And after that, inspect. So at this moment, I think the bladder, we have to be very careful about the bladder. Try to keep it down with a retractor once the peritoneum is open. Deliver the baby, and then we can visualize the ends. I think this kind of defect, there is no need to extend. It's already enough to deliver the baby. That's what it is looking like here. The defect is touching from, the defect is seen all around. But if necessary, if suppose it becomes necessary to extend, that I would prefer to be very careful and try a J-shaped on the left margin and not go lateral, because we don't know how defective the myometrium is internally, because it is a scar dehiscence. So very gently we can extend on the left side parallel to the lateral uterine wall if necessary. But most often in such cases, extension will not be necessary. Opening the peritoneum at a strategic point and keeping the bladder safe, that will be our motto. And we must remember at all times that the trigone of the bladder will be very close to the lower uterine segment in such cases.
And I think, ma'am, we also, the closure, I think it's such a thin layer on the lower side.
Very thin layer.
Upper,
so, correct. So when we have a lot of disparity between the thickness of the uterine walls, then it's important not to use tight closures. Sometimes we resort to interrupted sutures on the first layer. And when we do the second layer, important to keep the bladder away. And also, I think it's important to use a technique where the upper layer can be brought on to the lower layer with suturing. It is important to use the upper layer in two parts. The upper layer should be used in two parts. The inner margin should be sutured along with the lower. And when we do the upper margin, the upper margin of the remaining part of the upper segment, that can overlap the previous incision and come on to the lower segment. So that is when we need to be sure about bladder being down. Yeah.
Thank you. Yeah, and I think sometimes, not pulling too much, just approximating. We don't want to really, because it's not bleeding at all. Many a times it's just open enough, it's given up on its way. So no question of putting an incision on the uterus. The uterus is already open, rightly said on that. And yes, it is so extensible that the baby comes out. It's already on the verge of coming out actually. And as you can see, both the walls are so thin here that you need to go for a interrupted suture here.
Yeah, Dr. Mitra, interrupted. We can use add something. Sureka, I just want to give a message that it's very important to be sure about the hemostasis, because once the baby is delivered, suddenly it all becomes very oozy, So it's important to hemostasis, and if necessary, please go for the second layer, which can be a button.
Yeah, there should not be a question about whether you want to go for a second layer or not. If you need, you have to go for it, and you should not having a tight compartments here about the layers. Yeah, Dr. Mitra, you want to add something?
See, my personal addition would be that in previous cesarean sections, the scars usually don't bleed so much because they are quite avascular. Another thing is I would preferably keep my incision on the upper side, closer to the upper segment, so that once the baby is out, I would like to hold and feel the lower edge. It's appearing very thin, but this is the time, even if we haven't separated the bladder flap, it will be quite wise to see how much the bladder is adherent. Usually it may not be adherent and we may get a good plane. Sometimes if the patient's obstetric history is poor, that is the time we have been able to freshen up the edges and repair the uterus nicely if we are able to mobilize the bladder a bit down and get some muscle fiber from the lower edge also, because sometimes the healing is poor and there is muscle fiber even in the lower edge, but it is way down.
I get your point, Dr. Mitra, about trying to find out little space there and the uterine musculature where you can suture. We get the point there. So this question, I'm not able to see who this is for. Okay, this is for Dr. Pranjit. Same patient. The incision has got extended laterally. She is bleeding profusely. You are the consultant here. Now, how to manage this patient because the extension is lateral.
in such kind of patient, when there is a very thin scar is visible, I already will prepare my mind for this can happen. So preparation for the thing is first priority. Another thing, as soon as I notice that there is an extension, gently removing baby will may avoid the extension. But if at all it occurs, in that case, if possible, I'll exteriorize the uterus. I'll exteriorize the uterus. I'll try to catch the bleeder points with the green armitage. I'll try to take uterines as early as possible in this case. Also, the descending branch I will try to take. So after securing this, usually in 70% of the cases, the bleeding gets arrested. In a case where there is such a thin scar, usually only one of the uterine has got fire. So by taking the uterine, this bleeding is usually get arrested. By that time, the anesthetic will keep on his work of giving the uterotonics and all. Will take care.
Yeah, definitely. Yes. Pranjal, that's very rightly. Just wanted to again add in here that here the bladder sometimes, that bladder flap, if you have not prepared well or it's just given way. So I think here the sharp dissection is required so that the bladder can go down and you can take the hemostatic sutures well. And you can, of course, what you're talking of, if you want to do a uterine ligation here, again, that bladder flap pushing down is very important. So rightly said, you have to catch the lower fold, identify where the Mitra's fold. Please mute yourself, man. The computer you mute. Yeah. So that is how you go ahead. This is for you, Dr. Ashish. Now, if there is a vertical incision and you're the consultant on duty, not able to identify the lower end of the incision, what tips you would like to give to the viewers? Ashish is there? Ashish Kubde.
Yes, Sureka,
yeah, please.
This is very tricky situation. If juniors are doing, then they really need the help of seniors in this type of situation. First, check whether the bladder is well dissected, well away from the lower uterine segment or not, because you don't know the exact extension or angle to what level it has gone, this tear. Therefore, first see whether the bladder is dissected or not. Then second thing, in this situation, our olear stitch bilateral, it will really reduce the bleeding in this situation. Then number 3 point I will like to make, that instead of this routine Doyen's retractor or Deoli's retractor, if you use this Dever's retractor in this situation, it will give the very good retraction as far as this situation is concerned. Then what happens, you don't reach the exact angle of this tear. Then here the trick is, you take the interrupted suture in this lower uterine segment and just give pull to that suture, take another suture in the guidance of that previous one. Then, yeah, stay suture. Then you make the next suture as a stay one and take the advanced suture. Then again you make the stay, and in this situation you have to step the ladder and you have to reach the angle.
Yes, definitely. I think this is wonderful. And just I'd like to show a video here. See the sharp dissection here, which is being seen, so that you get what Dr. Mitra was saying, the previous case, that you need some uterine muscle where you can you want to suture. So this is one thing I would like to show about the sharp dissection. I go ahead and what Dr. Ashish was telling about, taking a suture, and with the help of that suture, you go below and try to find out with the help of that stay suture, you go below and you will be able to see. So 1 minute, I'll just move the video a little bit more forward. I'm so sorry.
Sureka, can I add one thing?
Yeah, 1 minute, madam. I'll just finish the video, and after that we will take your comment. Okay, just want to show this video. So just see Now this is the bladder, which is being, this is the incision which has gone vertically down, and now we are able to pick up the edges of that incision here. Now the first stay suture is being taken, okay, and with the help of that you will go and then again pull on that suture, and probably you'll be able to reach the angle correctly. So that's what I think Dr. Ashish was saying, when try to go at the angle and suture it, maybe with interrupted sutures or maybe with the even continuous locking suture can do, but interrupted will be good. Yeah. So Dr. Mitra, your comments, and we move
My
on to
comment
the
was only this, that in these types of uteri, where the lower segment is very thinned out, I change my needle size also. Choti size ki needle leti hu 20 or something, because we are only to repair that. I found out that agar bahut strongly karte ho, then it's the needle prick also starts bleeding. And such a jelly-like thin uterus, they have to be very careful, because we are only trying to approximate. We're not trying to make it, watertight or something. So just bringing it together. So find a needle we can use for the extensions.
Yeah. So we go to the next case for Dr. Supriya. She's a 25-year-old. Already the cesarean section was done. Post-operative period, we are finding that there is a lot of pallor in this patient, tachycardia, and you try to resuscitate her. She collapsed. You open her, you find a broad ligament hematoma now. So how to go about it? How to manage this patient, Dr. Supriya?
Yes, thank you, ma'am, for the question. So broad ligament hematomas, usually they get managed both ways, conservatively, but in this case, there's a massive, huge loss of the volume of blood is gone. So because she's fainted and she's not, so first we resuscitate her. We try to manage the hematoma by draining it off and carefully, so that it doesn't prick more vessels and damage more vessels there. So during actually I have come across very less, because there's very few cases of hematoma seen. So we manage it very carefully. While the surgery, we take care that all the vessels are sutured. We drain off the severe hematoma, continue to enlarge, require surgery to drain, and accumulated blood should be taken out, and vessels should be sutured back properly. And we see that there's no more hemorrhage from that site.
Yeah, Supriya, actually we find a lot, many times, these kind of cases being in institutions. So just showing you this video where actually there is a broad ligament hematoma which is being managed, and what is the trick is, of course, to open the leaf of the broad ligament. See, as you can see, the leaf is being opened here, yeah, so this leaf is being opened, and the ligament, the hematoma is being drained off. And then, as rightly you pointed out, that you would like to go and find out where the bleeding vessel is. So once you find out the bleeding vessel, then you take the hemostatic sutures on that, and you try to. So once you take the hemostatic sutures, one suture may not be enough. First of all, many a times it happens, you take the suture and still the patient is bleeding. So you have to assess that another suture may be required, and that is how you manage. And if you are not able to, then it is good that you could go ahead and do the bilateral
internal
for this patient. That would be good. Okay, and of course, as you can see here, the suture is being taken,
and I think it is
managed, and the hemostasis has been achieved. Another important thing is, after you have taken the suture, you should go back and find out if there is any posterior extension also. That also has to be found out, and see, as the surgeon is trying to find out if there is extension posteriorly. That is important. And of course, if need be, then the uterine artery ligation also may be needed in this case. So thank you very much. We quickly move on to the, yes, these are the important things to remember. Your patient may compensate for blood loss by tachycardia and vasoconstriction. Vitals may remain stable for 12 to 18 hours even with 3 liters of blood, the girth may not increase that much. So we have to be very careful in the post-operative period, monitor the patient well. And, if the broad ligament hematoma is there for more than 22 hours, it may be difficult to find out the bleeding vessels. And that is where the senior has to come in. And that is where you may need to actually, yes, Dr. Ashish has something to say.
I just have 2 comments. First, the surgeon's left hand is very, very important.
Yes.
It goes behind the uterus. It stretches the broad ligament. In the previous case, I'm telling you, it just stretches the broad ligament, finds out the avascular area. Before you move the needle through the broad ligament, you must do this vital thing that you take out the avascular area. In the second case, when you talked about broad ligament has to be opened, it has to be opened because it does 2 things. One, it exposes the hematoma. Second, it pushes down the bladder. So once the bladder is down, then most of the cases you don't find any obvious bleeder. So you have to go to the area where you find a little pinkish area, and then you catch hold of that with a kind of Babcock or green Armitage forceps, and then take the suture.
Yeah, thank you, Ashish, for that. And we move on to the next question. I've been trying to, take up all these practical.
Just one thing. I just wanted to say that when we do a cesarean section, the source of bleeding will be very close to the uterus, always. It will be very close to the incision.
Yes.
So it's important not to go lateral. Always try to find the solution medially only. The hematoma may extend laterally, maybe too much laterally, but the source will always be medial. So very often, if we dig laterally, we will cause more injury. We'll be very close to the ureter and the great vessels.
In fact, just trying the uterine
close to the uterus. Yeah, stay close.
Just trying the uterine may help us because they are always medial. The hematoma, in fact, can go in the retroperitoneal space also, but you may not. The ligation is not needed that laterally. Point well taken, ma'am.
And it's important to deliver the uterus and elevate it well to the other side. That is very important.
Actually, that itself, the bringing out the uterus itself puts the vessels on stretch, so the supply decreases. And our own hands, as Dr. Ashish has very rightly said, our hands are really, you press the vessel and then you can actually, see things much better.
Yeah, Dr. Mitra, this case is for you. And she was a case of obstetric labor. Bladder was drawn up adherent to the LUS. You kept indwelling catheter for 72 hours. After that, you find that there is incontinence of urine on the 4th day. So what do you think? What are your worst fears? How do you manage such case? Would you suture it yourself? Do you want a urologist at hand? And briefly, we can.
Okay, so as wonderful actually the deliberations are, the principle for every obstetrician is to remember that anticipate a trouble. So whenever we are doing a cesarean section in an obstructed labor or previous cesareans where there are adhesions, where we should respect the bladder. So this is one case. If there is obstructed labor, we have to understand that the bladder would have advanced. So inadvertent injury to the bladder, even if it has been done, if the obstetrician is careful about, keeping the intactness of bladder, that is very important for every obstetrician and every cesarean. So if that had been kept in mind, then we would not have landed up in this problem in this patient post-operative. So first thing is that always keep the bladder away from the field. That can be very easily done just by anticipation. Second is, it's always better to detect it on table. When in doubt, always confirm. There should not be any hurry to close the abdomen. There is no race to be run. So in such a case, if there is, there are so many clues. In obstructed labor, there will be hemorrhagic urine. Now that could be just because of the pressure of the head. But if it is that, it'll clear off during the course of surgery. But if we have injured the bladder and still there is hemorrhagic urine, we should not run to finish the surgery. I would rather take time, make sure that clear urine is coming. Otherwise, look into my field that have I injured the bladder or not? This is the best time to detect a problem. And it's very simple that through the transurethral catheter, just put in some more saline with methylene blue, so there will be obvious leak into the area. So basically, having closed the uterus, now's the time to respect the bladder. And the injury which happens to bladder in during cesarean is usually the dome of the bladder, which is a actually easier place to injure and repair by the obstetrician themselves. It's
Would
not
you do
so
it
difficult.
yourself or the urologist?
Yeah, I would consider calling a urologist if I'm thinking that I have injured the trigone. Because trigone, both the ureters are entering at the upper lateral ends. So whenever we are fearing that we have, injured the trigone, that is the time we should have a urologist. Otherwise, the dome of the bladder, which is most likely injured during cesarean section in such a case, that is pretty simple for obstetrician to repair. Of course, for our safety, we can have a surgeon, but the principles are very simple. Bladder is a very forgiving organ. So just 2-layer closure, 2030 Vicryl, that is what I would use. And before calling it a day, check the whether your closure is watertight. This is the time to put the methylene blue in the bladder and see for any leak. If there is, then you put another third layer. So the first layer is the mucosa and little bit of muscle, and the second would be the serosa. Just bring the layers together. No need to tighten it and strangulate it, but bring it together to make it a watertight closure. That's it. And I would advise 14 days of rest to the bladder.
Yeah, 10 to 14 days is advisable. Yeah, if you think that the injury is not very much, you think that there may be a problem, even 3 weeks of the bladder catheterization has been added.
And
just
I would
request
advise
that
urine
all the
culture.
panelists,
Urine culture
we want
is
to
very,
be
very
little
important.
more quick because Dr. Parikshit is waiting for us. This, I think, is for Jyoti, who's not able to join. So
now I joined
yeah, there.
because I came to the field. Yes.
She is at the previous LSCS. The cesarean section was uneventful, no unusual adhesions. However, she came back. She had. I'm not able to see. 1 minute. She rang up the consultant. She's having pain and vomiting. She's asked to return to the hospital. She comes here. She is having a distension in abdomen, which is tender to touch. What do you think is the problem? How to investigate and manage, Dr. Jyoti?
Actually, yes, on arrival, as it is on the third day of the third or fourth post-operative day. So first pass on the flatus tube and take her for the electrolyte, means the fluid, what are the parameter for the electrolytes, and the CT scan should be done. And most probable diagnosis is the intestinal obstruction, acute colonic pseudo obstruction, though it is very rarely written in the books. But in the tertiary care centers and in the civil hospitals and in our charitable hospital, it is very, very commonly seen because all the patients are malnourished, malhandled. So my diagnosis is, in this particular case, is acute colonic pseudo obstruction, as it is the fourth day of post-operative. And the course of patient, as you told, the patient refuses for laparotomy. So first treat her empirically. We should treat her by giving electrolytes and see for 24 hours and then repeat the CT scan.
Yeah, Dr. Jyoti, I think we should keep a diagnosis here. The surgeon has to come in and we need to take the opinion whether that could be a perforation or do you think it's, as you said, it's an ileus. So I think herein we need to take the opinion of a surgeon, and if you find that there is peritonitis and the possibility of perforation, and I think here in this case had an laparotomy because she was suspected to have a gut perforation. She refused for a laparotomy. She had to be transferred to a higher center where it was a cecal injury actually. And
actually, cecal injury, it may be cecal injury,
this patient was required colostomy, and that's why I think we should take a help of surgeon here and rule out perforation, peritonitis before you go in and so decide about what kind of management. Do you want to do an intervention? Do you want to do a conservative management? Depends on here. You could find that there was gut perforation, and And definitely, such
gut
kind of patient do land
definitely
us
we
into
should see the why the gut
litigations also.
perforation is there.
Yes,
Yes.
litigations
should see
also. You
na
have
ki
to
gut
remember counseling, documentation, proper specialist should be there with you so that you handle this case, this kind of case correctly. So you have to anticipate adhesion, vigilance during operations, and definitely you have to detect such kind of complications early so that you can manage surgically as well as medically. So, Supriya, have I missed your? No, I think she's already she has talked, right? So, few messages from this panelist. The cesarean section actually comes with lot of it's a package. It can be good, it can be bad, it can be ugly. You have to be prepared, you have to anticipate problems, you have to decide, prioritize your incision entry, closure, and if any complication, decide wisely and tackle effectively. With that, I would like to thank all the panelists and a great discussion, great panelists and stalwarts here. So with that, I thank you all, and Rashmi to take over for the next session, please.
Thank you, Surekha. Thank you, Charmila.
Thank you. Jyoti, you have to unmute yourself. We are able to hear meeting here. Yeah, thank you. Rashmi, is she there? Yes,
yeah, I'm here. I'm here, ma'am.
Please go ahead.
Yeah, I think because Dr. Parikshit answer has some other commitments, I think he has left because I think it was getting late. I think he's not here. So,
Sureka, can I say something? Surekha, please unmute yourself.
Please.
My one thing is, चाहे कितने भी cesarean कर लो, पर जब एक करने लगो, give your full concentration to that, and for every cesarean, have that same mental checklist that you did when you were first given the knife, so that you don't make a complication. It's complacency and some kind of preoccupation. If we think that we become an expert, आँख बंद करके कर सकते हैं, this is not the truth. Every case we should give our 100% concentration, anticipate, respect the organs, the bladder, the uterus, and also, as Dr. Ashish Mukhopadhyay said, the second hand, posterior aspect of the uterus. Many times there will be small bleeders on the posterior wall, and you would have missed them. Some endometriotic nodule or something. आपका uterine stitch line बिल्कुल सही है, rectus से bleed नहीं है, फिर hemoperitoneum है. Maybe there was something posterior to the uterus which we missed, and that is the reason that there was bleeding. So clean the pouch, clean the paracolic gutters, and spend some extra 5 minutes doing some job, so that don't be in a hurry to close the abdomen. This is the best time to make sure you don't have to come back again.
Yes, thank you. We had a marathon webinar of 3.5 hours, and we still have the participants who are there with us.
Surekha, if I can say something about detecting bladder injury, what we do.
Unmute yourself.
What we do is whenever we have had, we as Mitra is telling, we need to anticipate everything, and we need to anticipate before we start the surgery. We need to list in our minds what problem can happen and be ready to tackle. When we expect that bladder might have got injured, we connect it to a drip set and we run the saline up to 300 ml, not less. And methylene blue is not always necessary to pick up a leak. Just plain saline also, it's possible to make out if there is a leak, and we can only repair. The first layer, as you rightly said, is mucosal, and the second layer is seromuscular. And we can use non-tension sutures. The other thing is, once we have identified the area, we deflate the bladder and we repair the leak. And there is no recommendation for testing for leak. That's what I wanted to tell. There's no recommendation for testing for leak, because there is no point in putting pressure on the suture line again. one does a good closure end to end because one would have identified and then close, and that's it.
And keep it deflated. And keep it deflated. I agree with you. We actually
no need to test
all
for
the
which
panelists.
suturing has been done.
Lot of noises. Surekha, one observation from my end. Whenever Shobha Gudi talks, she always places her hand like this, and as if she is very, very frustrated and disturbed in life. But
I think there is a lot of noise.
Because of the noise, Ashita. Otherwise, why I'll be frustrated? I'm enjoying the
Shobha,
I take
Shobha,
the
I would rather advise that use this left hand of yours. And you purpose keep it behind the
The
user.
noise is from which phone I can't understand. Okay, so we go ahead, Rashmi, with the vote of thanks.
Yes, I really enjoyed the panel. Really
Thank you.
enjoyed. Thank you very much.
Thank you.
Thank you
Dr. Rashmi, kindly take over.
Yeah. Dr. Manisha, are you there?
Yes.
Yes. I invite you for the vote of thanks.
Yes, thank you, Rashmi. As we are concluding this webinar, I, Dr. Manisha Ghate, Secretary Vidarbha ISOPARB chapter, along with our Deoli, Sawangi and Amravati Society, would like to propose vote of thanks to all the stalwarts who have graced this webinar with their presence and words of wisdom. Today's chief guest, respected Dr. Purandare sir, and the guest of honor, Dr. Uday Thanewala sir, Chairperson ICOG. A big thank you to you both for sparing time from your busy schedule and sharing your words of wisdom with us. Our today's speaker, respected Dr. Sheila Mane madam, respected Dr. Pelli sir, Dr. Pushpa Zungare madam, a big thank you for all of you for enlightening us with your excellent and to the point talks. Thanks to our chairpersons, Dr. Jayant Kanan madam, Dr. Aruna Suman madam, Dr. Trishala madam, Dr. Preeti Kumar madam, Dr. Alka Mukherjee madam, Dr. Girish Mane, Dr. Vaidehi Marathe madam, Dr. Bangal sir, and Dr. Anil Rathod. Thank you all for sharing your thoughts and valuable time with us. Thanks to Dr. Charmila madam and Dr. Surekha Tayade madam for the wonderful panel moderation, along with the wonderful panel consisting of Dr. Ashish sir, Dr. Shobha Gudi madam, Dr. Mitra Saxena madam, Dr. Supriya Jaiswal ma'am, Dr. Jyoti Banglawala ma'am, Dr. Ashish Kubre sir, and Dr. Pranjal Sharma madam. Thank you all for sharing and discussing this most important topic of cesarean section. Thanks to Dr. Parikshit Tang sir, who has made and come out for some time. And thanks to our co-organizer, President of the Deoli Sawangi Society, Dr. Surekha Madam and Jaya Tulaskar, and Amravati Society President, Dr. Minal Deshmukh, and Secretary and Coordinator of today's webinar, Dr. Shalaka Bari, for supporting us. Then a big thank you to our convener and Joint Secretary of Vidarbha ISOPARB, Dr. Rashmi. Thank you, dear, because you have conducted this webinar with full strength. Lastly, Corona Pharma for giving us this webinar platform. And at last, with this, I conclude this session.
Yeah,
and,
thank you. And
I have a special mention here. 1 minute. Madam, special thanks to Nisha and Vasu sir and Abhishek for smooth conduction of this webinar. Thank you very much.
Yes.
So the last words probably. My team ISOPARB, all the executives, they have been wonderful, the type of work they have done. And again, I would request all of you to support myself for Clinical Research Committee, Dr. Pushpa Zungare for Medical Education Committee, and Dr. Manisha Ghate for No Violence Against Women Committee. So thank you very much, all of you for joining, and have a great. Yes, Dr. Supriya is there for Adolescent Health Committee.
Yeah.
And so, so
and Shamila madam also. And Shamila madam.
is there.
Shamila madam is there.
Thank you. You can stop the.
Charmila doesn't need support, but Supriya does. Supriya, did you mention? Supriya does.
Yes.
Madam, I always need your support, ma'am. Always
I really
need your support.